तो इसमें कभी आप ऐसे डाल देना, ठीक है। छोला भिजवा है तो वो छोला में होगा और सब ऑडियो तारीख में है बगल में सब सामान यहाँ भी है, जितना इसमें ऑडियो था सब चलेगा। हाँ आईपी पासवर्ड सेम है सब जगह। ओ अच्छा, और हाँ पता नहीं क्या करना। हाँ हाँ, ऐसे ही सारा शुरू लगता है, तो आपका दुकान। ये तो इसका वाइट है,
इसका लग गया है।
बोलो ना। नालंदा
लॉगिन रूम नंबर लिखा हुआ है, क्लाइंट लॉगिन लिखा हुआ है, रूम नंबर लास्ट नेम लिखा हुआ है। हाँ, क्लाइंट लॉगिन लिखा हुआ है। ऊपर नीचे सबके ऊपर है। हाँ, गेस्ट गेस्ट टू
हाँ हाँ, नालंदा का चिपका इसका नालंदा ना इधर बगल से किताब है। इतना क्या कहाँ हो गया 8 मिनट
हो गया।
इसमें देना उसको वाइट में तो स्क्वायर से कर दो
अब हो गया, कट जाएगा। अभी शेयर में सब कर दिए।
तो इसमें कर दो देखो कोई मदर तो बोल ना बढ़ जाएगा तो तार होता करता तो ऑडियो चेक कर लिया उधर से आ रहा ना माइक
ये कैमरा में नहीं लगा है, वो वाला डिवाइस कहाँ है?
कैमरा लगाए वो डिवाइस दे देता है कैमरा लगाएगा ना तुमको कैमरा में इसे आउटलेट लगाओ, डायरेक्ट चला जाएगा, कोई इशू नहीं है। कोई छोटा सा भाई लगा रहा है, वो तो यहीं पर बोल रहा है कहाँ पर है। कौन वाला लगाइए क्या? इसको तो नहीं वाला, वो वाला था ना, क्योंकि इसमें वो आउटपुट देखो कैमरा कर लेगा, उससे आउटपुट
कैमरा तो कोई काम नहीं।
अगर हम जो मशीन लेते हैं मन कुछ हुआ तो इधर तो उसमें लगा देगा। नीचे क्या लगा? नीचे हम लगा लेंगे अपना वाला।
आगे
अच्छा बात, तो अभी जाएंगे यहाँ स्टार्ट कर, इसको खाली लगा दो, कैमरा लगा उसको। नेट किस में देना है? इसमें
अब दे दिए हैं।
आपका मोबाइल कहीं थोड़े रहेगा, कितना तो रहिएगा।
नहीं,
बंद करिए, और कोई थोड़े है। मोबाइल देने से नहीं ना होगा, इसको
अभी क्यों ना सोच रहा था कहाँ पर ये
मोबाइल लेके जैसे ही
बोला
भर
वो कहाँ पर है, जोड़ कर
एक काम करिए ना, ये हो गया उसको ऑन करें, उस पर आईडी ऑइलिंग खोल दीजिए, वो हो गया। नीचे तो लाइन
और इसमें जोड़ा दिला दिया तुम्हारा कहाँ पर है? कहाँ पर है? हाँ तो एक तार उसमें लगा दो बड़ा, ला लगा ना। हाँ हाँ, इसको कर दो, फिर दिक्कत हो जाएगा तुम्हारा। दोनों वाईफाई पर नहीं बर्दाश्त करेगा, थोड़ा देर के बाद बाबू में जाकर जाएगा। ये वाईफाई रहेगा, मदर नहीं कटना चाहिए, समझ गए?
जांच करवा देंगे अभी लाके।
उसको बांध देना, खिंचाए नहीं है, थोड़ा साइड से कर दो इसको अंदर से, देखो यूपी से बाहर से।
इसमें यूएस भी लगता है, पावर भी लगता है।
हाँ
इसमें पावर भी लगता है।
टेप मार देंगे, वो जरूरी नहीं है, वो तो लगेगा तो लगा देना। नहीं उसे नहीं लगा था, ऐसे तो डायरेक्ट उसका नेट से खोलो। हाँ हम जैसे खड़ी करो वैसे लगाएगा। एंड कर दो अभी, क्या कर एंड करके फिर से लॉगिन करो। क्या कुछ नहीं लगा, ऐसे लगा देखो यूएसबी निकालो ना। नहीं आएगा,
सुमित आ गया, लैपटॉप दिया ना, लैपटॉप उसमें
दिया तो इधर आवे कर
दिया है।
वो लेते हैं
हाँ
जाएगा तब ना आउटपुट देगा हो
हैं?
पीछे।
हाँ अरे ये काले वाला रेड लगा दिया। लो ये उसका उसी में है, डाल दो बैकग्राउंड डाल दो। उसका नहीं है कुमार यहाँ तो। नाम सलाम,
ये बोले कि इधर से वो आउटपुट लेके भी डालने के लिए हो उसमें
है उसमें आउटपुट।
अरे इसमें तो थोड़ा इसका ऑडियो भी इसमें डाल दो।
कहाँ डाला है? ऑडियो है ना, आउट करने वाला भी ना उसमें। इसका
तुम्हारा उसमें नहीं है,
इसमें ना है, उसमें है।
इसी में डालो ना।
तो ये उसमें लगा है। इसमें डायरेक्ट कैमरा लगा है ना, एचडीएमआई से लगा है। अरे यार
कैमरा एचडी में तो
दो क्या दो जाके थोड़ा यहाँ हाँ हो नीचे क्या वो
पैनल डिस्कशन है ना। पैनल डिस्कशन के लिए हमको एक मॉडरेटर का चाहिए, बैठ के होगा और ठीक है। अमन ना बोलो, हाँ बोलो। हम्म 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 तो हो सकता है कि खाओ हुआ हो, ठीक है, कल जाकर साफ करवा दीजिए, ठीक है। छोटा सा सीजन लेके साफ कर दीजिए और ड्रिल करवा दीजिए और एंटीबायोटिक दीजिए। वो इन्फेक्शन है, ठीक है, वो इन्फेक्शन है, उसको साफ करा के ठीक है। पतला टेबल, हाँ तो ये तो बहुत दिन से होगा तो गाढ़ा हो गया होगा, उसको फिर प्रॉब्लम, ठीक है। ठीक, हाँ कल से है, कल से। इधर खाना लगा रहा है क्या?
नहीं,
हमने वही पूछ रहे कि क्या स्टॉल लगा दिया है, ठीक है। ठीक है, आपको यहाँ पे पैनल डिस्कशन है पहला। तो एक दो तीन चार, तो तीन तो आपको यहाँ पे हो गया, ठीक है। और एक और चाहिए, ठीक है।
नहीं कल तो हो गया, तो क्या तो हो गया।
यहाँ पर आइए ना, समझ लीजिए इसको। पैनल हो रहा है ना,
माइक यहाँ से ऑफ कर दिया।
नीचे दिशा चला जाएगा।
साथ नीचे पैनल क्या है, कंटिन्यू कर दो, ठीक है। उसके बाद प्रो कॉन्सेशन वो है, ठीक है। उसके बाद फर्स्ट टॉप है, ठीक है। बस यहाँ एक कॉल करेगा, दिशा बहुत करती है, फिर तो कंपटीशन है, और उसके बाद वो अपना खत्म होगा, उसका
कैमरा निकाल रहेगा।
हमारा है 3 पेपर। और ये और ये हो गया, तो यही ना, हमको क्या है ना, चार ले रहे हो
जिसको जा सकता है
हम आप करेंगे क्या
तो थोड़ा सा
वही है, किसी के बारे में प्रश्न देना है,
5 लोग का ही पहुंचा है। छोड़ने में जो होगा
नेक्स्ट यहाँ पे काम करते हैं, अगर हम उसके लिए आसान करते हैं उनको
5
कॉल कर रहे हैं, तो
मेरा रेडी है, नीचे से फाइट करेगा, पीछे नहीं बोला
ये तक ऊपर जितना लिखा हुआ है उतना ही जो केयर पर्सन है वो इंट्रोड्यूस करते हैं। तो जाने को कर देंगे नहीं सब लोकल ही आप जो ऑनलाइन टेक्नोलॉजी ऑनलाइन आर्टिस्ट सब जानते ही, राजू पे सब जानती है, काम करते हैं रवि से तिवारी हुए कभी तो भी है ये आदमी काम लोग बाकी तो आपका होता है, उनके बारे में कुछ तो जानते ही कहाँ से क्या है कैसे। हम तो हमको ज्यादा इंट्रोडक्शन थोड़ी देना है।
चलो नीचे चलो।
यहाँ देखिए नहीं, ये प्रोटोकॉल सेशन के लिए लगाया नहीं है भाई।
जी सर।
यहाँ पे है ना, आप बोल इसमें है ना।
जी सर, कैमरा है सर।
वहाँ कहाँ भाग गया सर?
क्या यहाँ पे लगाना भाई सर? सर
ये यहाँ पे प्रोटोकॉल सेशन है, 3 और 1 4 होगा ना।
तो इस पे वही आप लोग करते हैं टाइम तो इसमें है रोशन बाग पहला सर यहाँ और
सरिया में आपको सरिया में आपको देख सकते हैं।
इसमें क्वेश्चन आया है।
आपको देखिए ना कौन है?
ये तो फोन दिख रहा था, फोन पे कर ले।
पिन कैसे चला? हाँ माइक नीचे वही था।
इस और में आपने उसी को देख रहे हैं, पहले राकेश सर कॉल करने के बाद ठीक है, उसके बाद आप वहां से फ्री हो जाइएगा। तो सर को इंक्रीज कराना होगा ये आप बता दें।
हम बता नहीं, आप मुझे थोड़ा क्वेश्चन खड़े तो हम बताएंगे भाई, मतलब एक उसका फ्रेंड यहाँ खड़ा है तो क्या
लिखा कुछ आइडिया नहीं
नहीं बोल लेंगे, आप लिख लेंगे, गंदा गंदा
आपकी बात हो रही है, आपके बारे में बताएगा कौन? सीवी देना चाहता है, लिखना है आपके बारे में।
अच्छा दे देती हूँ।
अच्छा सीवी है आपका सीवी है?
सीवी है मैम।
सीवी है क्या? जरूरी बात है।
जस्ट अ सॉर्ट ऑफ इंट्रोडक्शन।
या
आपके बारे में उसमें है क्या, प्रेजेंटेशन में है? आपके बारे में ठीक है।
I need to introduce them or somebody else will be introducing the families.
I will start, madam.
Okay.
Like all the persons or only the moderator.
It's up to you, whatever you can tell me. That case, please give me सबका CV. or rather you would be displaying the CV, right?
सीवी नहीं है हमारा नाम बताते हैं डेजिग्नेशन कहाँ से एक हिस्से में क्या करना है
मेरा पति ना ऐसा फोटो डाला था कि मुझको भेजे ही नहीं I kept on asking him कि दूसरा फोटो दे दो और ये किसको देना है आप लोगों में से पेन ड्राइव में क्या आप बस अनाउंस करोगे कैसा बताओ आप मेरा
मैडम आप ऐसे करें क्योंकि इसमें इस कंप्यूटर में डाल दें ताकि फर्स्ट स्लाइड रहेगा तो उसको पढ़ दूंगा या आप किससे प्रेजेंट करेंगे इसी कंप्यूटर से प्रेजेंट
ये
करेंगे
करोगे कनेक्टर से कनेक्ट कर दे
हाँ कनेक्टर से कनेक्ट कर दीजिए आप पहला स्लाइड पे ये रख दीजिए मैं यहाँ यूज कर दूंगा
मॉडल तो खड़ा रहेगा
चलिए आप भी बैठिए
हमें भी चेक लगवाते हैं
इस तरफ बैठ सकते हैं या सामने ही बैठ सकते
हाँ यहाँ पे यहाँ पे चेयर लगा देते हैं
हाँ जैसा करिए वो स्लाइड्स ऑटोमेटिकली चेंज होंगी ये कहाँ पे स्लाइड चेंज है
स्लाइड आपको चेंज करना स्लाइड बनाएंगे क्या
क्वेश्चन ही लिख दिया है तो
अच्छा हाँ वो उसके लिए ना हाँ तो बस एक स्लाइड डाल दीजिएगा जो भी लगा रहेगा
हाँ
उसको
दो स्लाइड्स
स्लाइड चेंजर कोई नहीं होगा तो यहाँ खड़ा होकर चेंज कर देगा जब भी आप लिए उसको यहाँ एक आदमी तो रहेगा ही ना उसको बोलिएगा बस वही स्लाइड है ना
देखो
हाँ तो
ये
बस
same
उसको
question
रोटेट कर देगा नहीं भी होगा स्लाइड तो इसको छोड़ देते हैं गलती है
क्या उनको देखो मैं सॉरी कहाँ है तुमसे
ये इस साइड ये कंप्यूटर है किसका है दिला भैया आप देख रहे हो कंप्यूटर
ये किसका है हाँ बुला दे रहे मैंने किसी फैकल्टी का है
स्लाइड में ऑलरेडी वर्ड भी रहता है ना ताकि इसको पॉइंट्स डाल देता है
हरी भैया किसी को एक को ऊपर भेज दीजिए ना संकोच रहा है
मैडम आप सेम में फर्स्ट स्लाइड वो कर दीजिए उसके बाद
हेलो?
मैं हट जाऊंगा तो उसके बाद आप नेक्स्ट स्लाइड
भेज दीजिए ना पॉइंट याद रखना सीक्वेंस थोड़ा
I'm just relying on you people to last sentence का 3-4 word होगा ना उसी को catch करके and repeat it and the next question.
Actually, you have to memorize everything, and you don't have slides to just इसके बाद ये order.
ज़्यादा पहले के मत पूछेगा मेरा ना गोल हो जाएगा तो फिर नहीं पूछेगा ये तो मीटिंग क्वेश्चन पूछना है
साइड ये बैठे लोग बुलाना होगा तुम लोग 4 लोग रहोगे मैं वहां से स्टार्ट करके यहाँ बैठ जाऊंगा 5वां आदमी कौन
अच्छा वो हम लिखता है पूरा ऑर्डर में नहीं
इसमें ये क्योंकि चल नहीं आपको फर्स्ट स्लाइड दिखेगी
हाँ सर
इनपुट है भाई बॉक्स में डालना उधर जो बजेगा ना इधर सुना देना चाहिए हाँ टेप निकाल के को रह गया वहीं पर रिसेप्शन के सामने फोन करो ना वहाँ हम निकाल के रखे थे वहीं रह गया
बस बताते रहिएगा
ये ना
टाइम को
ये ना
है ना
हाँ हाँ
ऊपर से पैनल के लिए हाँ हाँ मुझे कंप्यूटर कनेक्ट करना है कनेक्ट करना है इसको तो आप हटाएंगे मेरे कंप्यूटर को कनेक्ट करेंगे
ये कंप्यूटर को हटा दे
हटा दीजिए और मेरा कंप्यूटर कनेक्ट कर दीजिए
चलिए
सब टीएन झा वाला में है ये डॉक्टर कुणाल आप ये चेतन को बोल दीजिए ना जो भी फ्री हो उसको भेज देगा आया हुआ है
तो अगर आए भी होंगे तो वो लोग उसमें सेशन सुन रहे
हाँ बट कोई भी फ्री होगा तो मेरे पीछे स्टार्ट करेगा
ये कनेक्ट करना है
हाँ ये कनेक्ट करना है
ये कनेक्ट करना सब HDMI है इसमें VGA वाला नहीं है इसमें कनेक्टर आपका
जो कनेक्टर मैंने आपको दे दिया
ये लगवाना
पेन ड्राइव है आपके पास हाँ तो पेन ड्राइव दीजिए उसमें मैं ट्रांसफर कर देती हूँ
ठीक माउस काम नहीं करता है। वो समस्या है।
नहीं काम कर रही कष्ट करना तो हो रही है।
सिर्फ पेन ड्राइव है, पेन ड्राइव उधर है।
पेन ड्राइव दे रहे हैं।
ठीक है। ठीक 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 है।
हाँ हाँ जी। हाँ जी।
ऑडियो का था, ऑडियो में आ रहा था। 10 का बाद तो आएगा।
हाँ हाँ ठीक 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 हाँ हाँ ठीक 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 हाँ 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 ठीक 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 हाँ 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 ठीक हाँ 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 ठीक हाँ 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 ठीक ठीक हाँ हाँ ठीक ठीक हाँ ठीक ठीक हाँ 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 ठीक हाँ हाँ ठीक ठीक
ठीक ठीक ठीक
HDMI कर दीजिए प्रोजेक्टर को।
ठीक ठीक
बज रहा है ना? तो ठीक है, ठीक है।
हेलो
थोड़ा बढ़ाइए।
हेलो चेक हेलो
ठीक है।
ठीक ठीक है
ये कनेक्ट करके देखो आ रहा है नहीं कुछ।
नहीं, काम नहीं करता है इसमें, तो माउस से काम नहीं कर रहा है लैपटॉप में। ऑडियो डाल दिए हैं अपना। ठीक है, सब चालू है ना? हेलो हेलो को हो रहा है? अच्छा एक मिनट एक मिनट। हेलो हेलो चेक साउंड बढ़ाइए थोड़ा। हेलो हेलो चेक बढ़ाइए। हेलो 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 हेलो
Good morning, everybody. Welcome to the very first session on day 2 of ISACON 2021. This session is on communication skill in anesthesiologist. Communication is a very important skill and a lot of emphasis has been given on it in new CBME curriculum, because it has been seen that lots of the problem are everybody in society. Welcome to the very first session on day 2 of ISACON 2021. This session is on communication skill in anesthesiologist. Curriculum, because it has been seen that lots of the problem are everybody in society. Welcome to the very first session on day 2 of ISACON 2021. This session is on communication skill in anesthesiologist. Good morning, everybody. Welcome to the very first session of day 2 of ISACON 2021. Communication is a very important skill and lot of emphasis has been given by National Medical Commission in their new CBME curriculum. Lot of problem in today's society is occurring, either because of the lack of communication or because the message is not conveyed to the relatives in a right way. Anesthesiologists usually have a very limited time to interact with patients or their relative, and they are involved in the critical patients or involved in the care of the healthy patients in whom sometimes some critical incidences occur. So it becomes very difficult in those times to communicate the message to the relatives. So put more light on this topic, this panel discussion has been arranged. I would like to introduce to you the moderator for this session, Dr. Chandani Sinha. Dr. Chandani Sinha is an additional professor in AIMS. She won the first e-poster in European Society of Regional Anesthesia Conference in 2018. She started acute pain clinic in AIMS, and she is a faculty in palliative care. She has more than 80 publications to her credit. Dr. Chandni, please proceed.
Thank you, sir, for inviting me here. So I would be introducing my panelists first. So we have Dr. Kunal Singh, who is an associate professor in Department of Anesthesiology in AIMS Patna. Then we have Dr. Swati. Dr. Swati is assistant professor in IGIMS in the Department of Anesthesiology. And Dr. Vishal Weber, who's assistant professor in Department of Anesthesiology, ESI Patna. So as all of you know, communication is quite important to all of us. So when you actually look at any standard textbook of anesthesia, what do you see? You find the term communication actually missing from, there'll be no section. In fact, there'll be no chapters on communication. But needless to say, communication is very important for anesthesiologists because we tend to interact with lots of people, be it the patient, be it our colleagues, be it our supporting staff at various settings, in the pain clinic, in the OT, in the ICU. So we would be discussing about the role of communication and its importance to all of us. by discussing a case scenario. So the case scenario is, we have a patient, Mr. X, is a one old male patient who sustains injury in the right knee while playing football. The MRI reveals that there's an anterior cruciate ligament injury for which he needs to be operated. He needs to undergo arthroscopic repair of the ligament. Now, the past history, the patient reveals that he's undergone tonsillectomy at the age of 15 years under general anesthesia, which was uneventful. But post that, he's developed vocal cord polyps, and he says that it was due to passing of the tube through his throat during the procedure. And he attributes the vocal cord polyps to the exposure of general anesthesia. The patient also gives a history of undergoing hernia surgery around 2 years back, which was under subarachnoid block, and he has been complaining of low back pain on and off post the procedure. Other general examination or history is unremarkable. Now, if you're the attending anesthesiologist seeing the patient and the patient is apprehensive about both general and regional anesthesia, how would you go about? What are the various aspects given in the case that needs to be addressed preoperatively, and would good communication skill be effective in this scenario? Dr. Swati, would you just throw light on this?
Very good morning to everyone. Thank you, ma'am, for such a pertinent question. All of us have celebrated World Anesthesia Day on 16th of October. And one of the slogans that widely circulated was, "We care when you're unaware." Though it is a catchy slogan, my opinion differs from it. When the patient comes to us in the first pre-op visit, that is when the patient comes under our care. The PAC, apart from its traditional role of taking a good medical history, seeing the patient, formulating a plan for anesthesia, it goes beyond that. And it is the first point of contact that we as the anesthesiologist have with the patient. It is a moment when we can, by our good communication skill, we can instill confidence in the patient so that he feels comfortable enough to come to us with all his or her problems. Now, good communication skill not only helps the anesthesiologist do our job better, it also empowers the patient. It gives us a subconscious connect with the patient, and it empowers the patient to be a part of his own anesthesia care, thereby making him an active participant rather than a helpful or a helpless or a mute subject in his own care. Now, when we come to this particular patient, he has apprehensions regarding both general anesthesia as well as regional anesthesia. The first point that I would do is first to talk to the patient and understand as ma'am has clearly stated, he has some apprehensions regarding general anesthesia, saying that the general anesthesia was his cause. He attributes vocal cord polyp formation to the exposure to general anesthesia. So we need to assure him and to make him understand the best we can that general exposure to general anesthesia or the passing of tube through his throat or his vocal cords is not the cause for vocal cord polyps, and there might be another reason attributed to it. Now, when it comes to regional anesthesia, we have to explain to him that yes, there is a 0.8 to 1% chance of subarachnoid block causing low backache, but that is a very small chance, and there might be other reasons that you can attribute to having some physical factors or some other reason that could be attributed to having a back pain after subarachnoid block. Now, after explaining all this, and only if the patient asks us, which in most situations they do, what will be your preference, or sir or ma'am, doctor, what would you prefer to, as our course of anesthesia management, then we can tell us what our rationale for giving a subarachnoid block in this particular case for a lower limb, for a ACL repair would be, and we can talk to him about it and alleviate his concerns. But it has to be ultimately the patient's choice, and we do not force our choice upon the patient. That is what we usually do. We tell him that this is the best course and this is what should happen. But that is now not how we should communicate. We should tell him these are the options, and this, if he asks, this is the best we think we should do for you, and then whatever the patient decides has to be the final.
Right, Dr. Swati. communication, in fact, is not only about words. A lot of emphasis has been put on non-verbal and paraverbal communication. Dr. Weber, could you just tell us what it is and the role in communication?
Good morning, everyone. Thank you, ma'am, for giving the opportunity to talk on the non-verbal communication skills. In fact, non-verbal elements constitute about 93% of our communication skills, with only 7% of what we speak being contained in the words we speak. So it's very important for us to understand, before going on to the role of non-verbal communication and its significance, I would like to first highlight what are actually the non-verbal communications are. In fact, our face also reveals a lot many things. So facial expression is actually something which helps you to give message to your person who is listening, that what feeling you have, like anger or happiness, everything can be expressed by a facial expression. Similarly, body posture and movement of the body while you're communicating with somebody is also important, like your bearing, your stance, how you are standing, or you are simply looking somewhere else. So all these matters. And then comes the gestures. As for example, right now I'm talking to you, I'm also moving and shaking my hands. So basically, this gesture also has a significance and carries a message that I'm trying to communicate, I'm trying to reveal what I'm feeling, and I'm trying to give you the message which I'm actually having in my mind. And then comes the touch. Touch is equally important. Actually, you can say a patronizing pat on the head or a controlled gripping in the arm for any person can be of great advantage for the message which you want to actually give to the patient. Similarly, a weak handshake or a warm handshake, that is also important. All of you must have seen that movie, Munna Bhai MBBS. In that, it was shown a Jadoo Ki Jhappi. There was a common phrase about that. So actually, touch carries a lot of message. Then comes the spacing. We all need a physical space. And for the physical space, actually it depends upon the culture, our traditions, the closeness of the relationship. And that space can be used to show even aggression or the dominance. So actually how you give the physical space, how you use the physical space is an art. Then comes the voice. Actually, what you say matters less, because people actually tend to read what you speak. It is not only the voice, it is the tone, the pitch, and the flow of the voice also matters. Like if I am running fast, you'll not be able to get what I'm trying to say. So voice also matters. So having said all about the types of nonverbal communications, now I'd like to highlight actually what role it plays. So the role it plays is something like it can cause substitution. It can substitute for what you are saying, or it can cause repetition. It strengthens the message, what you are trying to communicate. Then it can cause contradiction. Like if you are saying something and your gestures are saying something else, the listener may develop a mistrust. So that is one of the issues also you should take care of. And then comes accentuation. So whatever you have said can be accentuated by simply pounding a table. While we are talking, you have seen in the parliament, they pound the table if it goes according to their favor. And that shows a gesture of, yes, we are accepting what you're saying. So these are the significances of the non-verbal communications, roles of the non-verbal communications. And when I talk about the significance, yes, obviously, when your non-verbal skills match with what you are saying, actually it creates a sense of trust, clarity, and rapport. Whereas if you do not communicate with what you are saying, then it actually creates lack of confidence, mistrust, and misunderstanding. And it creates a lot of confusion. So it's very, very important that whatever you are saying should be connected well with your nonverbal skills.
Very true, Dr. Weber. In fact, non-verbal and paraverbal communication is much more important than what you actually speak out to the patient. So Dr. Swati, supposedly this patient is taken up for surgery, and after giving the subarachnoid block, develops hypotension, severe bradycardia, and has to be intubated and put on vasopressors because of the complication. And the patient gets shifted to the ICU after that. So how would you communicate an adverse event to the relatives of this patient who are not at all actually anticipating this event?
Ma'am, first of all, whenever we decide to do a procedure on a patient, now the patient, however helpful we want the patient to be, at most times the patient does not always understand what we are trying to explain. So the process of explaining a adverse event, it actually, if we have empted the patient and the patient's attendance, that any form of anesthesia has some inherent risks in it. So if we are performing a regional block, there might be a very small chance, but there might be a chance of complication. Patient might have a fall in blood pressure, fall in heart rate. All those things have to be explained while we are taking a consent for the patient. Now, a consent process has to be an active and a fluid discussion between the patient and the anesthesiologist, rather than a one-way street where only we communicate and the patient just listens to us. And at the end, we expect him to sign a document. Instead of that, since this patient has already had past bad experiences regarding both exposure to general as well as regional anesthesia, our focus should not be only to explain the procedure or the risk factors to the patient, but we also should alleviate all whatever anxiety that he has regarding the procedure that we are going to perform. Now, if we have done this, our job at least decreases by 20 to 30% in case an adverse event occurs in the during the intraoperative course of the patient. And like in this case, the patient had a high spinal, needed to be intubated, had to be put on vasopressor support, had to be shifted to the ICU. So in this case, the patient is the primary victim, but the attendant and the patient's family are actually the second victims. It is very important in real life scenarios when we try to explain something to the patient's attendants. Where do we commonly do it? In the ICU corridor, in the corridors in front of the ICU, or standing at the ICU doors. But that is not where a communication of an adverse event, or most an anticipated or even an unanticipated adverse event, should not happen in these bad settings. It should happen in a safe, comfortable, and a private environment where you can sit down with the patient's attendant, explain everything that happened during the course of anesthesia, what and where the complications arose. And it does not mean that because we are talking about complications, we are admitting fault. Complications arise in any surgical or in any time a patient has come for treatment in the hospital. Any complication can arise. So it is very important for us to make them understand that this is the complication that has occurred. This is our present course of treatment. This is why the patient was put on inotropic support. This is the reason why his a tube has been put down his throat, and we are giving him ventilatory support, and what to expect during the course of treatment when the patient is likely to recover. If we can give a timeline to the patient's attendants, that will be a very good thing, that this is how much time it will take for the patient to recover. Or we think that the course might be stormy, or we expect the course to be smooth. And after some hours, the patient will wake up, things will get better. And then we can, reassess the situation at that present time. This event, this disclosure that we do is not a one-time event. It has to keep repeatedly happening every time the patient's situation changes significantly enough that we think an interaction with the attendant's family is required. Because at this juncture, we cannot talk to the patient directly. So all the communication has to happen to the patient's attendants. Secondly, when we, in this setup of the ICUs that we normally have, the patients, we have our shifts, the nurses and all the technicians, all the staff in the ICUs, they all have shifts, and we all work in 6 hours, 8 hours, or 12-hour shifts. So what happens is the patient has been treated by multiple doctors. The attending anesthesiologist will also come to see the patient. The consultant in the ICU will also see the patient. So when there are multiple doctors, OT staff, nurses, everyone who is taking part in the patient's care, the message to the patient's attendant should be very clear and should be one. There should not be multiple messages going to the patient's attendant. When there is a discrepancy in what you are conveying, or what the nurse is conveying, or what the technician might be saying, or even what the security guard at the gate is saying, then that leads to just unnecessary fear in the minds of the attendants. And that is where the doctor-patient bond suddenly breaks. and the patient expects, that it only creates suspicion in the mind of the patient, of patient's attendant, that something is being hidden from them, or an adverse outcome has not been correctly represented. So all these things, if we take care of all these things and communicate well in the ICUs, half our problems and the things related to patients breaking things, we cannot completely eliminate them, but we can deal with them if we consider the patient's attendance emotional status also, and we deal with it accordingly.
So moving on to the next subset of patients, the pediatric patients. The pediatric patients are in fact very difficult to handle because it is not only handling the patients per se, but their relatives and their parents who are very sensitive about their kids. So Dr. Kunal, how is communication skill useful while handling a pediatric patient? And do you have special methods to adopt while handling them?
Thank you, madam, for putting up very important questions related to the pediatric patient, the subgroup. So my co-panelist has beautifully explained how we can explain the patient's adult patient, but when it's come to the pediatric patient, it is a very different place to be in. And what happens that it is easier to explain a adult patient. They understand your language, they are more emotionally matured, and that is not the case with the pediatric patient. They are more emotionally fragile, and they require more of a care and empathetic this value also. And to make and also the good communication does really improves the health outcome. And if not, if the connect with the children or the pediatric patient is not good, then really the effects are really opposite. Like when we talk of induction, so if the communication is not good with the pediatric patients, and if the rapport has not been developed, then it can lead to violent induction, and which can ultimately lead to post-operative behavioral disorder. And then if the multiple surgery has to be performed, then it leads to neurobiological long-time behavioral problems also. So we have to be very particular when we are dealing with the small kids. Also, to make the things complex, there are three members when we are communicating with the pediatric patient. It is not just the anesthetist. There would be a pediatric patient and also parents which are accompanying them. And those parents are very emotionally charged also. So when it comes to the health of your baby, you are more concerned. And first, you will have to also address their problems, their concern. You have to listen their what their anxiety is. Then you have to talk to the child also, and there is a dynamic between the child and the parent. So all these things has to be kept in mind while we are dealing with the pediatric patients. So really, how do we learn this communication skill? Mostly through our peers, through colleagues, but sometimes everybody may not be so good at explaining the skills or demonstrating the skills. So American Board of Pediatrician has recommended that there should be a formal training. So that could be imparted to everyone, because it requires a unique set of skills. So formal training is very important, and some of the modules has been recommended. Few of them I want to suggest is, one is Lord's method, where L stands for first listening. So communication is just not giving the information, it's also receiving the feedback from the patients also. So first and foremost, the most important thing is listening. Then there is acceptance of the reality. So you will have to accept what the patient is telling. So if you have to tell that, oh, I know you are going through such a trauma and such a pain. Also, you have to rephrase the sentences also. So when you rephrase, say something like, if you're putting the patient in sleep, so ask them that I will put you in a sleep as you daily go to the sleep, and you will get up later on, and nothing will go wrong. So these are the things which has to be done. Then there are some positive suggestions that you can make. So positive suggestions are, when you are putting a propofol, we are giving a propofol. Don't say that it will hurt you a slight or hurt you a light. Whenever you put these negative terms like sharp, pain, it really create an anxiety and panic, and all the consequences then again happen. So without using these words, we can say that, oh, you will feel something like ice going through your veins, or you will feel something cold running on your hand. So these are the ways we can modify it and can change it. And to make the situation worse, it is COVID. Now wearing a mask over your face and then talking to the patient makes it more difficult. So this is a really challenging point. Now it is by, as the Dr. Weber has said, that it is not only verbal, it is facial expression also. That is all gone without the mask. So we have to learn and adapt to the recent, how to tackle in these set of scenarios also.
Thank you, Dr. Kunal. In fact, all of us use those negative phrases. Thoda dard hoga, very commonly used. Dr. Vaibhav, how is a good handover done in the PACU?
Ma'am, I couldn't guess.
How is a good handover done in the anesthesia unit, post anesthesia, post?
Well, that is the important part. In fact, when you hand over a patient, it actually, it's not just getting rid of what your task was. Actually, you should get familiar with the situation that whenever you are handing your patient to the recovery, the personnel who are there in the recovery room, say for example, the staff nurse, they should be well communicated about the patient's status. The patient should be comfortable, and you should be also comfortable that, okay, my patient is in such and such condition and I'm in a position to hand over the patient. Unless and until you are satisfied, you can't go ahead. And also it is very important to give the instructions to the personnel who are there, or the nurses, the attending doctors who are maybe junior doctors, that what care and what advice you have mentioned, they are strictly adhered to. Also, the fellow surgeons should be informed whether they have left any packs or any catheter which needs to be removed. So that has to be taken care of. So handing over simply means actually your communication skills with your co-members, your co-staff, and your co-doctors as well. It's not just communicating with the patients, because that helps you alleviate all the anxiety and apprehension in you yourself as well as in the patient. So I think it's very important to do a proper handover.
To Dr. Weber, actually not only post-operative advice, even the intraoperative events which have occurred has to be conveyed to the staff or the doctors there, which includes the fluid which you have given, the drugs which you have given, and the post-operative advice should also contain the drugs which have to be given, the positioning of the patient, and even before shifting the patient, you have to make sure that you go and see the patient once more. Just in case that doesn't happen, just make sure at least you're reachable on the phone. That is, you need to give your phone number there and make sure that the staff there knows where you're available. As in, if you're in the OT, they can call you, and just in case of an emergency. Dr. Swati, could you tell us about the role of good communication in palliative care?
Ma'am, definitely palliative care patients are a subset of patients who are dealing with sudden bad news. A serious news or bad news is the term that is commonly used. They have been either diagnosed with a terminal illness or something that has suddenly shortened their span of life. Now that can come as a shock to anyone, even the most learned and educated people. So dealing with that is a very important and a very something that has to be meticulously planned and not just randomly shared with the patient. Now, there is something called spikes, though it is a very unfortunate word, but spikes stands for setting up the scenario first, setting up the proper where you're going to talk to the patient, not just any random place, but a proper clinic or a place where you can sit with the patient, gathering all the knowledge that is required, preparation of all the documents, all the checking whether all the documents that you are of the actual patient, if what is being said is correct, connecting with the patient and their attendants, being very coherent and being very precise in what you're saying, not being vague or using terms that are so difficult that the patient or the attendant, even the most learned people will not understand. So all these things will help us, and there has to be a patient and family centered communication instead of that being only focused on the medicine part of it, or that or the lack of treatment or the lack of treatment options any further. It has to be patient centered, family centered, so they understand that whatever is being done, or a shortage of treatment right now, or a treatment that is not required or that cannot help anymore, does not plunge the patient into depression or darkness, though even after explaining everything, it still might happen. But our focus should be that the patient understands and the patient's family understands. Nothing is left unsaid as far as possible. Nothing is vague. And we do not talk to only the family members or only the patient. It should be a discussion that should happen with both the family members, the attendants, as well as the patient themselves. And that good communication will help the patient quality of life, and the remainder of life that the patient has, that will be improved.
True, Dr. Swati, one thing in palliative care we should all take care of, not to give any false hope to the patient or to the relatives. That needs to be emphasized. Dr. Kunal, talking so much about communication, what are the usual barriers which we face during communication?
So to understand the barriers, first we have to know the communication process as per se. So communication, the process involves a sender who sends a message, and that is through the medium, which could be verbal, which could be non-verbal, like gestures and tone and all, and then it could be written. And then there is a receiver who perceives this message and then gives a feedback again to the sender. So any of these steps, if not done properly or not communicated, will lead to a miscommunication or misinformation, or leads to various anxiety and all. So there are various points which has to be kept in mind when we are communicating with the patients or colleagues or whatever, or anybody else. So first is, when we are talking about the patients, the time is very important. Now, everybody is so busy and the schedules are so tight. OT is so busy. And nowadays, many cases are posted. We hardly give any time to the patients. And it has been found in the research that once the patient starts talking, we stop him before 20 minutes, 20 seconds. So when you do that, this again create a anxiety among the patients, and they feel that you are not listening, you are not understanding the problem. It doesn't matter how skilled you are, it doesn't matter how expert you are in your field, but if you are not giving those time to the patient, he will never be satisfied that he has been treated uh, in a good hand. So the time is very important, first of all. And as we have a very we are a very large country, and many languages, regional languages are being spoken. So language is again a barrier. So it is better if we could learn or talk to the patient in their own language, because that is what they can understand. So many patients are not educated, and they might not be knowing even Hindi or English. So we will try, one should try to talk to the patient in the lower, in their own language, so that they can tell their problems and we can understand what are the problems which is they are facing, and then we can console them. So language is another barrier. Again, there are many other barriers which can play a role, like environmental, emotional. So when we counsel a patient, really we sometimes we do in a PAC clinic, we do in a OT corridors. So most of the patient might not be comfortable in speaking about their habits, their smoking habits, their talking about their bowel problems. So they might be comfortable if not, they might not be comfortable if there are many people around there, or there are too many noise. You could not understand what he is speaking. So the environment which that all this discussion and communication is going on is also very relevant, and it should be kept in mind while we are counseling the patient. Then again, other problems, another This barriers which can hinder the communication is disabilities. Some patient might not hear well, some patient might not see well. So these disabilities also hinders the good communication. So it is very important when we are doing the communication, all these points are to be kept in mind. And last but not the least, the medical jargons we use. We often use bradycardia, tachycardia, hypotension. So even literate patient sometimes cannot understand these medical terms, and this again increases their anxiety. So it would be better if we talk in the simple, make it simpler for them to understand. We talk about saturation, oxygen saturation. We can modify it and say that level of oxygen in your blood. So the language has to be simple. It should not be complex. And even if it's local language and the language is not simple, the patient will not be able to understand it. So these are the points which should keep in mind while we are communicating with the patients. And
thank you, Dr. Kunal. Though Dr. Kunal has actually spoken about the barriers faced and even the way outs, I would like to ask Dr. Vaibhav just to re-emphasize what he's actually said.
Thank you, ma'am. Really, I'm thankful to my co-speaker, Dr. Kunal sir. He has not just given the problems which are actually faced, he has also given me the solutions to overcome the barriers to communication. But then again, I would like to emphasize, because it not just starts with simply the overcoming the barriers. Actually, the tool of the trade is first we need to establish a rapport. And unless and until rapport is established with the patient, you actually cannot do that. And when you try to establish a rapport, the first step should be to acknowledge what the patient is actually feeling. The acknowledgement includes the feeling of anger. And once you have sorted out all the causes of anger, then only you should try to resolve that issues. It should not be like, only you have taken care of one of the cause of the anger and you are trying to resolve it. It won't work. So try to acknowledge the feelings which the patient is having. And for doing so, I think it is very important, which sir has already said, to listen to your patients. It is very important. Give them time to come out with their problems and what they feel like. And for this, it's not just listening. And actually, you don't need to be silent. You need to prompt your patient to come out with the feelings. And for this, I think it is important to ask them questions. The questions can be very simply, it can be an open question, it can be a closed question. If you ask the patient about the closed questions, the simple answers are yes or no. So they will be coming out with the feelings that, okay, they are feeling good or not. So they can simply answer it yes or no. They are feeling pain, yes or not. So once they start communicating, then you can go on for the open questions, which are actually more fruitful and they give you more information about the patient's outcome. Then equally, it is important to develop self-awareness. Now, what I mean by self-awareness is that whatever our feelings are and whatever is going in our mind, it should not interfere with our job in hand. So it is very important. And we also need to emphasize upon one fact, that we should not make pre-assumptions. Like when we talk with the patient or their relatives, we very quickly formulate our ideas about what the patient's values are, feelings are. And actually, we should rely more upon the facts rather than the assumptions. So assumptions don't play a role in communication skills. Do not assume that the patient may be comfortable, or try to realize what actually is happening. Then sir has really pointed out very well that jargons should not be used. Yes, if you are using euphemism or you are using some slogans which are really difficult, maybe it's very easy for us to understand, but it may be very, very difficult and misinterpreting for the patients or their relatives. So always try to understand what the patient has already understood from your communication. If you allow them to speak, you will get words, how you can make them understand in their language. And yes, language also needs to be taken care of. It is always better that you communicate with the patient and their relatives in their own language. The moment you switch to their own language, a feeling of closeness actually establishes between you and the patient. So if you do not feel like you are not comfortable with the language, you are not knowing the language, try to have an interpreter with your by your side who can actually convey what you are trying to ask and what the patient is communicating back to you. Then besides all this, basically all the communication and conversation has a beginning, a middle, and the end. So in the beginning, you should be very much well aware what is the purpose of the interview. And my another co-speaker has very rightly pointed out the importance of the environment. So it is always better to communicate with your patient in a safe environment where the patient is comfortable and you are also comfortable. In fact, it helps you to allay the fear and anxiety if you are about to break something up, some bad news or anything like that, not just for the patient, for you yourself also, it is very, very important. So take care of the environment. Then in the middle, you try to develop a feeling of trust with the patient and their relatives. And in the end, you actually convey your message in the form of a thank you or a good boy and goodbye, or in the form of something. If you are breaking something which is not favorable with the patient or relatives, try to offer them help. As for example, could you arrange for an ambulance services if the patient needs to be transported because of the unavailability of the bed on your side, on your hospital? So that is very important. If you try to help out your patient while you are actually dealing with that, something which is not favorable with their outcome, so you need to offer them help. At least you should do that. And I seriously feel that, in spite, ma'am has very rightly pointed out in the very beginning that most of the anesthesia textbooks do not mention anything about the communication skill teaching. So anesthesia training should actually incorporate, it is now the demand of time that communication skills be incorporated in the anesthesia chapters and in the anesthesia training programs. It is very, very important. And in fact, universities should come up with particular training modules, and other books should also incorporate these chapters. And in fact, the Royal College of Anesthetists, they have incorporated their anesthesia training modules in their FRCS programs. So it's also, it needs to be universally implemented throughout the world to overcome this problem, because I feel that is actually, there is no algorithm, there is no gold standard for developing a communication skill. There is no confidence interval, so you cannot judge how beautifully you are actually communicating. But then again, this should be formed curriculum for the teaching in anesthesia training programs.
Thank you, Dr. Weber. So one of the common notions that people have, that people are born communicators. People who communicate well, they have this God-gifted ability. That's an innate quality. So do you actually agree with this, Dr. Kunal? And would you also suggest means to improve the skills among residents?
Yeah, ma'am, rightly said, some people might be born communicator, but I am not. So most of us learn it by the practice. And this is how it is said that with the past decade of experience, we have learned that this communication skill are measurable, teachable, and then it can be taught also. So I've already previously I've said that most of us, we learn by our peers, our colleagues, with the practice with the patients, but there should be always a formal training also. And it has been emphasized by many societies. And also, as Dr. Weber has said, that the Royal College has incorporated, and many other countries have incorporated this communication skill training program in their curriculum. So these communication skill program, which includes a few of the modules which are given, which are popular, is one by Bayes Institute, one is given by Cambridge, and there is a consensus, and broadly it incorporates like opening the conversation with the patients. So this module in the first step is how do you open a communication with the patient. Then the second step is how you gather the information. So by you have to be at the same time empathic and sympathetic towards the patient, and same time you can gather the really important information you can from those patients. And then there is you have to be patient, you have to give time, and then you can close the this conversation at the end. So MCI has also included way back in 1997, but it was not emphasized in our course. But now with the newer courses which has been added, with the newer method which has been incorporated, something called as ATCOM clinical skill training program has been emphasized by the MCI, which says attitude and communication skill learning program. So this has been implemented in a phase manner for the undergraduate MBBS course. So in first phase, those who are in undergraduate of first to third semester, then the second phase is training the undergraduate who are in early clinical phase, and the third phase is those who are in their internship. So some of the competencies which we want them to learn is taking history, then examining the patients, how to open the communication, how to break the bad news. These are the skill we want them to learn. And various modules, various methods to teach them are there. Obviously, the traditional method are by group discussion, lectures, presentations, but these are not really effective when it comes to teaching the communication skill. So most effective method to teach them is by video, making the video. That could be real time. The recording of the patient doctor interaction could be recorded, or it can be simulated. Both are very helpful, and those students can see this video and understand how to communicate it better. Also, the other method is the role play. So a role is given to the students. Somebody becomes a doctor, somebody becomes a patient, and then a scenario is given, it is discussed, and the whole thing goes on. And after this, a script is done and the play is over, the feedback is given by the faculties and the peers. So everybody learns from this role play. But one of the drawback of the role play is that it is really difficult to play a part of a patient. Being a doctor, we really never understand what the patient's feelings are. So these are the various methods we could teach the juniors and the residents, and it has to be assessed also. The assessment can be done by written examination, but nowadays OSCEs and clinical examination is a better method to assessing them, and this can be cannot be taken as a separate entity, but can be done where the history taking part is going on, where the examination is going on. There we can accommodate this clinical skill. We can put some points for the clinical skill also. So these are things which are being done by MCI to improve the clinical skills in our medical students and residents.
Thank you, Dr. Kunal. Actually, ADCOM is a welcome step by the government. And to end it all, Dr. Weber, could you just tell us in brief the benefits of good communication from an anesthesiologist's perspective?
Well, ma'am, the benefit just not limits to the patients. Obviously, the patients are going to get benefited from the communication skills if you are a good communicator, and they can be numerous. It is beyond imagination. You can decrease the post-operative pain. The patients recover faster. They have less functional limitations. In fact, it allays the anxiety, the fear, the apprehension which the patient has if you are a good communicator. Then similarly, it also actually builds up feeling of trust. So if you break down, if you give news which is not favorable to them, so that can also have do not have any catastrophic events occur in the if you are breaking a bad news. So if you are a good communicator, there's definitely advantages to the patients. But then again, it's not limited to the patients. The doctors and the entire nursing personnel, the entire OT staff, they are also benefited if you are a good communicator. In fact, it actually helps to clarify all the misunderstandings if it can ever occur. And in fact, incidences have shown that if there is a good communication between the operating room personnel and the staff and the nurses, it is actually going to cause less of mishaps. So studies have proven this. So it should be very well communicated between not just the patient, between the doctors as well as the colleagues as well. So actually, in fact, the workload management, decision making, conflicts which can occur in the OT room also, they all can be sorted out if you are a good communicator. At the same time, it is not just patients and the doctors who are going to get benefit. Overall, the institution, that is the health providing institution, is also benefited if you are a good communicator. If you are a good communicator, the patient is going to give a better feedback. They will develop trust in the institution. And definitely because of that, you can obviously expect lesser number of litigations to the health providing institutions. So it is one of the very important benefits in today's era, I think.
Okay, thank you, sir. With this, we come to the end of the panel discussion. And I would like to thank you all the panelists for the excellent presentation of a difficult topic. Over to you, sir.
Thank you, moderator Dr. Chandni and all the panelists. It was very nice panel discussion. And in the session, no questions from the audience will be allowed, but I am confident that so many people have joined electronically and all would have become benefited by this. Now I would request to come Dr. Asutosh Jha to come and give memento to our panelists. First, it will be given to Dr. Swati, panelist, Dr. Swati. I would request Asutosh Jha to give memento to Dr. Kunal. I would request again Dr. Asutosh Jha to give memento to Dr. Vishal Vaibhav. And finally, I would request Dr. Asutosh Jha, sir, to give memento to Dr. Chandni, who has so beautifully moderated the whole session. Thank you for joining this session. Thank you very much. Now we move to second session, that is the pro and con session. And the topic for this pro and con session is opioid-free anesthesia. The moderator for this session is Dr. Kishore Jhunjhunwala. Dr. Kishore Jhunjhunwala has graduated from MGM Medical College, Jamshedpur, and did his post-graduation from Banaras Hindu University. He is presently working as assistant professor in Nalanda Medical College Hospital and is also working as a director, Palika Vinayak Hospitals. So now it is over to Dr. Kishore Jhunjhunwala for conducting the session.
Very good morning to all the participants and sir for the nice introduction. So today's topic, what we are going for is the opioid-free anesthesia. As we know, the entire medicine is moving toward the precision. So individualized treatment required. And we are always upgrading ourselves what are lacking in our treatment plan and how we can improve. And so the patient will get maximum benefit. So in this sequence, we have a discussion. So I would like to invite Dr. Ojha. He's assistant professor at Nalanda Medical College Hospital and my colleague also. We are working together and he's going to take his presentation on a opioid-free anesthesia. And our next participation is Dr. Srividya. She's presenting online from TMA Jamshedpur. Welcome to Dr. Srividya. And I hope at the end of the day, we all will be benefited with this presentation. Now it's over to Dr. Ojha, Dr. Nitin Ojha.
Very good morning to all. First of all, I would like to thank to the Patna Scientific Committee, Patna Society of Anesthesiologists, so that they're given me an opportunity to take a talk on this opioid-free anesthesia. And I supposed to talk on the pro sessions, that is the pro concepts of this opioid-free anesthesia. And I would like to thankful to the Dr. Kishore sir. He's our senior at that medical college, and even is my mentor also. And thank you, sir. Thank you, sir, for the kind words. We start the topic about opioid-free anesthesia. First of all, go for the definition of that. OFA is a technique where no intraoperative, systemic, or neuroaxial or intracavity opioid is administered during anesthetic. Actually, the main thing is that the fashion come and fashion goes. And in our medical field, we are also very dependent on these fashions. And our fashion is totally dependent upon the effectiveness of the tools and the safety guidelines of the patient. And the recent years, we witnessed that in the field of anesthesiologists, there are new trend or new concepts of this opioid-free anesthesia. And this trend starts from the past rational use of opioids. And this actually the kind of pendulum that has swung over the past rational use of the opioids for eradicating or eliminating the use of opioids to the perioperative and the post-operative also. And this is a new paradigm from Muller and de Kock. And in the beginning of our, at the beginning with ether administration since 1847, they shifted to the basic balanced general anesthesia. After that, with the improvement of with the development of the potent synthetic opioids like fentanyl, we shifted to the opioid low anesthesia. That is opioid balance anesthesia. We are shifting to the opioid low anesthesia. And after that, this trend with the feasibility and the safety of no intraoperative opioids, we are in the state of opioid-free anesthesia. The main concept that we are coming to the next stage, that is the next ultimate step, is the opioid-free anesthesia and analgesia. First of all, we should also concern about why we use opioids in anesthesia. Why most of the perioperative physicians are using opioids still now. Opioids were primarily used initially because of their safe intraoperative profile with minimal cardiac depressions, blunting of pain transmissions, and provide the basis of post-operative pain control. But with the hemodynamic stability, we can use this very specific drugs of alpha-2 adrenergic agonist, clonidine, dexmedetomidine, and beta receptors of antagonist. The news, this is a study which is research clinical anesthesiology. The studies that do we feel pain during anesthesia? There's a critical review on surgery evoked circulatory changes and pain perceptions. Pain, we all know the pain is a very subjective phenomena. And when the patient is under general anesthesia or the coma state, the term pain should be replaced as a nociceptions. Because nociceptions is a neural process of coding. There are various mediators involved in pain pathways: serotonin, noradrenaline, enkephalins, and peptides. And anti-nociceptions can be obtained by interfering with various neuromediators. So the interfering with enkephalins by using opioid is not only the solution. So I mean to say that opioid is not only the exclusive soul of providing analgesia. There, if you go with this the pain pathway. So what are the alternatives? What are the methods of opioid-free anesthesia? How we could perform this opioid-free anesthesia? First of all, there are basics to primary management. That is the peripheral sensitization and the central sensitizations, and the prevention of OIH, and other is weight-based dosing on drugs. Now, for the management of peripheral sensitization, we go for the local anesthetics like peripheral nerve blocks, lidocaine infusion, steroid, dexamethasone, NSAID, all these things. And the management of central sensitization is maybe go for propofol, etomidate, and the glutamate antagonist, ketamine, N2, magnesium, and the pregabalins. See, this is a complete cycle which performing opioid-free anesthesia. It provides all these the components we are using, we need in the general anesthesia, hypnosis, symphylosis, amnesia, hemodynamic stability, immobility, and neuromuscular blockade. Now, what are the OFA benefits? All we know, just stable hemodynamics intraoperatively, no respiratory depression, no addiction, less needs for post-operative ventilation, no nausea and vomiting, no GI dysfunctions, failures, no pruritus, no urinary tensions, and prevention from chronic pain. Why the indication? It means we must use for this OFA for those patients with a history of narcotic abuse history, acute and chronic opioid addictions, opioid intolerance, morbidly obese patient with obstructive sleep apnea, hyperalgesia, history of chronic pain, and those patients who requires less analgesia requirement. And the IRAS guideline that enhance recovery after surgery and anesthesia, decrease the post-operative nausea, vomiting, decrease post-operative pulmonary morbidity, COPD, asthma, decrease the histamine release, allergy, and patient satisfaction, most of all. These are psychologists. Now they say we comes under some studies. There are lots of studies we done, which done. We go for the PubMed also, but I just chosen for the selective ones. That is the opioid effects on airway. In this study, they demonstrated the upper airway reflexes, and another reported a decrease in respiratory complaints. This is a study, the review article, which is done by Zemin and MD et al. And this is other study. This is a study which is done in the bariatric surgery. And the main background of this study is that in bariatric surgery is commonly associated with the post-operative nausea and vomiting. And this study, the author mostly compared the PONV among the bariatric surgery patient and randomized to opioid-free patient. Even though the prevention prophylaxis of beyond prophylaxis, still the those patients are used with opiates are having still the incidence of PONV. And this is a surgery which for the orthopedic surgery. They also use with the nowadays the opioid crisis also, and the use of this study protocol. They found that the opioid-free anesthesia is still better, and always better for this from the elective surgery we planned in our OT. And this is the study is basically this is the prevalence of sleep disorder breathing. Those patients with a chronic use of opioid, and we administered the opioid also. On that, the prevalence of central sleep apnea in all population receiving chronic opioids is much higher than the general population, about 24%. And the prevalence of sleep disorder breathing, all population receiving chronic opioid high is 42 to 85% of incidence. Is the opioid risk, which I already discussed earlier also. And the main problem is day to day we have those using chronic opioid, opioid-induced hyperalgesia. It is a state of nociceptive sensitization caused by exposure to opioids. And the condition is characterized by the paradoxical responses where a patient receiving opioid for the treatment of pain might actually become more sensitive to certain painful stimuli. And this is a chronic opioid consumption produces changes in CNS similar to the central sensitization, and they activate the mu receptor, which increase the effectiveness of glutamatergic synapse at NMD receptors, resulting in OIH. And still we having the barriers for the OFA practice. The main is the resistance to change. Basically, these are some psychological also that to use of giving these opiates. And I might think these changes can be made if having some evidence-based data. If we provide the need for more research and evidence-based data, and for much more the confidence of using opioid-free anesthesia during post-operative. And other thing is a lack of training, and other thing is that the lack of knowledge of some other drug also. The other drugs like Ismalol, and most of the trainees are not using this drug, maybe not having lots of proper guidance or knowledge, and insufficient guidelines and limited data. These are the current barriers of OFA practice. And this is my reference, and this conclusion state. Okay. Conclusion is that the opioid is not coming in the slide, but opioid-free anesthesia is is having potent of to perform this in our anesthesia field, and it might be helpful to the patient and the effectiveness to the safety control.
Thank you, Dr. Nitin, for your nice presentation. And I hope Dr. Srividya will give some more insight against your opinion. And I'm waiting for the strong opinion of Dr. Srividya. Dr. Srividya, are you connected with us?
Yes, yes, I'm here. I hope you can, I'm audible. I hope I'm audible. Good morning. I hope I'm audible.
You are your voice is not, we are not hearing you, Dr. Srividya.
Am I audible now? Am I audible now?
Yes. Yes.
Yeah. Is it strong enough?
What voice is little less? Yeah.
Is it okay? Is it better now? Good morning. Is it better now? Am I audible? I think I am. I can hear my voice. I need to share my screen. My screen sharing is disabled. Am I audible?
Hello.
Am I audible?
Well audible now. Now you can share your screen also.
So is my screen visible?
Yes. Chat box will be there.
Yeah, and my voice audible?
Yes. You are listening to my voice, ma'am?
Yes, yes, I can hear you.
Okay, ma'am. You start your presentation.
So at the outset, thank you, Chairperson, for a very kind introduction. And good morning to all of you, ladies and gentlemen, bringing you greetings from Jamshedpur this morning. And I must really congratulate my compatriot, Dr. Nitin, for really having presented his point very effectively. And in the next few minutes, I will try and counteract whatever that he has said, and therefore try and bring your opinion around to side with me. So I know that many of you in the audience would have been some sort of movie buff, Bollywood or Hollywood, and would have really seen this movie, The Princess Bride, a very cult Hollywood movie. So in that, and one of the characters, Mr. Vizini, keeps repeating the word that is inconceivable, to which another character, Mr. Montoya, keeps saying this line, you keep using that word, but I do not think you know what it means, you think it means. So this is absolutely apt for the general use of the term opioid-free anesthesia. And I would like to tell you why it is so. Now, usually fashions come and fashions go, and changes in medical practices cannot be changing like a fashion fad. So they have to be the evidence-based, they have to be effective, and at the same time have to be safe. So therefore, it is very difficult to equate, opioid-free analgesia or opioid-free anesthesia with a fashion fad. And that is what I'm going to prove now, how much of a fashion fad it is. So, but I really do not blame the anesthesiologist for taking up on this very technical, or rather a very jargon or a fashion fad, because the definition itself is very confusing. So what is the definition? Dr. Nitin has already shared that. So you look at it, it's opioid-free anesthesia as a technique where no intraoperative, systemic, neuraxial, or intracavitary opioids are administered with the anesthetic. And the technical term out here, or the operative term, I should say, is no intraoperative. So, but no intraoperative, that means you can give opioids at any other time. What about from the time when the patient enters the theater to the time when surgery ends, or further still, if the patient preoperatively is taking opioids to the time when the patient leaves the operation theater. So if you administer opioids at that time, that is not an opioid-free anesthesia. So that is where the whole concept of opioid-free anesthesia lies, and we are not taking care into the entire perioperative time as it is. So, but it does not. To understand why this started, one should go into what is the background. So it all started when United States Congress declared 2001 to 2011 as a decade of pain control and research, and pain was decided as the fifth vital sign. There is nothing wrong in that. It, however, prompted a very liberal use of opioids to control the pain. There was pharmaceutical industry pressure, and that, of course, led to opioid overprescription. And because there was opioid overprescription, what happens is a lot of pills got taken home in the post-operative period. They were lying unused, and therefore they were being used by people other than whom for it was prescribed, and therefore that led to what today we call as an opioid crisis or an opioid pandemic. So much so was the opioid pandemic that in the decade between after 2000, you can see an exponential rise in the kind of opioid use that is going on for the especially in the United States and the Canada. And also, with the increase in opioid use, it caused an increase in the number of drug overdose deaths, and that increased by a whopping 182%. Of course, then that became a choice for concern, and physicians started talking about it, and then anesthesiologists jumped into the bandwagon. So what did? They decided that they should stop using, they should contribute to killing this menace, and therefore they should stop using intraoperative opioids, and therefore the term opioid-free anesthesia developed. Now, Should we really blame the opioid crisis by solely because anesthesiologists were using intraoperative opioids? Let us look at some evidences. Here you can see that Brandel et al. Saw what is going to be, what is the opioid prescriptions like in the postoperative periods for patients who had undergone opioid-free anesthesia intraoperatively, not opioid-inclusive anesthesia. So patients were discharged with lots of opioid prescriptions. Even when they had low pain scores, they were not taking any opioids preoperatively, and also they were not taking any opioids just before discharge. Yet they got a lot of opioid prescriptions to take home, and then that led to pilferage. Then again, what happened to these opioids when they were taken home? About 92% of the patients said that they did not use any of these opioids because they had already got adequate pain control. And then 77% of those patients who took the opioids home said that they were not keeping it in locked containers. As a result, postoperative prescription of opioids went unused, were unlocked, were undisposed, and became a reservoir for opioid, and therefore this could cause an injury and death. So are opioids itself used in the intraoperative period to blame for this? And or do we need to look at ways in which we prescribe the opioids in the postoperative period, the main cause of this menace? And that is why the absolute jargon term of opioid-free anesthesia is an absolute no-no, according to me. So the proponents of opioid-free anesthesia will always look at something like Dr. Nitin already said, that these are the causes by which opioid-free anesthesia, these are the reasons for which opioid-free anesthesia have to be used. One is it reduced postoperative nausea, vomiting, prevented persistent postoperative opioid use, prevented opioid-induced hyperalgesia, caused decreased adverse effects or respiratory depression, and had no role in and had prevented opioid cancer progression. So let us look at it. But where in all this did we talk about post-surgical pain of patient? Did we talk about the pain relief in patients? And did we really think about what is going to happen to the patient who has inadequate pain relief? Like if 80% of patients who whose post-operative pain was inadequately treated found that it was a risk factor for chronic postoperative pain, and then it caused other complications like sleep disorders, increased infections, also increased readmission rates, and also patients had less satisfaction and also regret having had surgery. So really, do we need to restrict opioids? So what we did here by restricting opioids was start a vicious circle. First, there was a fear of opioid crisis. Because of that, it became opioid-free anesthesia. Then again, you did not treat acute postoperative pain with, did not treat pain with opioids, and therefore, because of that inadequate treatment, patients had shifted to chronic pain, and then finally there was again that menace started. So you can see here that it really is not very, very good to use opioid-free anesthesia. And we do know that opioid analgesics are the strongest opioids that we know. So is it really ethical to not treat patients with who require opioids? To not treat them with opioids when they require them. So what are the evidences thereof? We must see that the opioid-free anesthesia is basically based with most of usually conjectural evidence, lot of personal experiences, and there is a paucity of randomized controlled and multicentric trials. However, there are some, so we must examine them in detail. So this is one such review article which has examined the importance of opioid-free anesthesia, and they have found that the postoperative pain scores are similar to that with opioid-based anesthesia, and they had reduced nausea, vomiting. But what do you do when you see examine it completely? When you see it well, you will find that they included about 1,000 articles, but at the same time, they found that it is very, very easy. And when it was seen, they found that only 11 articles were included for review. And when you do the risk bias summary, you find that more than 50% of the cases or the trials had some degree of risk involved. And when you look at what was the modality of post-operative analgesia, all the cases or most of the cases really required post-operative opioids. So the authors themselves have found that there are some limitations, and therefore additional trials are required to see the anesthetic, to see if such a system is effective in health setup. Again, the recent most review on opioid-free anesthesia was published in Anesthesia in 2019. Similar findings here also. And similarly, only 10 more than previous trial, 23 were included. Also, about 40% of them had a propensity towards bias. And again, the same goes. Post-operatively, they required, they all had fentanyl infusions or remifentanil infusions or PCA morphine. So it really wasn't opioid-free at all. Again, the authors found that there was several limitations and literature would benefit from additional trials. So the most important criticism that we have for opioid-free anesthesia, opioid-based anesthesia, is that there is an increased risk of PONV, but most of these trials have not told us whether they have used a prophylactic antiemetic as is required by the guidelines on both American and the European side. Again, the other criticism is causing opioid-induced hyperalgesia. You will see that most of the trials included remifentanil was used as the intraoperative opioid of choice. So one needs to ask the question whether the opioid-induced hyperalgesia post-operatively in the opioid-based group was because of this drug. So there are several evidence to this. One is that remifentanil is a very ultra short-acting opioid, needs to be given in an infusion, and patients have reported, once infusion is stopped, patients have reported that they have a high degree of increased levels of pain. So pain scores have rapidly shot up. So that is one of the reasons why it can be attributed to, remifentanil can be attributed to opioid-induced hyperalgesia. Again, we are very worried about opioid-induced respiratory depression. But then it is usually as already Dr. Nitin said, it usually happens in some subgroup of patients, like patients with obstructive sleep apnea, cardiac and respiratory diseases. So really, do we need to have the one size fit all? That means we must avoid opioids in all sets of patients, or identify certain high-risk patients and try and avoid the opioids in those subgroups of patients only. And again, opioids have been implicated to increase the risk of cancer or progression of recurrence of cancer, but there is no level 1 evidence to say that opioids cause cancer progression. So let us look at very, very recent reviews. This is one which is a critical review of opioid-free versus opioid-sparing approaches. And this has been published in Anesthesiology only this year. So the authors have been very, very scathing of the opioid-free strategies. That is, and they say that however noble it may be, does not acknowledge the gaps that are presented in the existing evidence and clinical practice. It does not allow for analgesic titrations. They are not very clear about what are the optimum components that you should use, and it does not serve to decrease the risk of persistent opioid use. And therefore, they are merely distracting us from optimizing pain of the patient. Again, the most important trial that we have had till date for opioid-free anesthesia, for comparing opioid-free anesthesia as a randomized controlled trial, is the POFA trial, which has compared a balanced opioid-free anesthesia with dexmedetomidine with balanced anesthesia for remifentanil for major and intermediate non-cardiac surgery. So what did they do? They had two groups. One group got remifentanil, another group got opioid, and all the groups got intraoperative propofol, desflurane, dexamethasone, lidocaine, ketamine, neuromuscular block, and whatnot. Okay. And so what really happened with the results? The results was that study had to be stopped prematurely. Why? Because 5 cases had severe bradycardia in the dexmedetomidine group, and 2 patients also had asystole. Hypoxemia occurred in more than 72% of patients in the dexmedetomidine group, and Also, dexmedetomidine patients had delayed extubation and prolonged post-anesthesia care unit stay. So they concluded that the trial refuted the hypothesis that balanced opioid-free anesthesia with dexmedetomidine compared with remifentanil would result in a fewer adverse effect. And however, it resulted in greater serious adverse effect, especially hypoxemia and bradycardia. So really, friends, we should really reconsider using the technique of opioid-free anesthesia, because it's rare for a trial to be terminated for safety reasons. And in this trial, it was shown that the advanced adverse events could not be decreased even when the dose of dexmedetomidine was decreased, because that also caused such serious side effects. So now that we've come to this safety, let us talk about how difficult it is to administer, if one considers to use opioid free anesthesia. So how cumbersome it is. So just looking at the diagram, it's pretty confusing. I can see if you put the patient at the center over here, how many infusions would he be receiving if he's getting OFA? 1, 2, 3, 4, 5. 5 infusions. Look at how you have to juggle with all this. Then what about the equipments that you need? What is the safety profile of all these drugs? How are you going to titrate them? What kind of monitoring are you going to use when the patient is on so many infusions? And last but not the least, of course, what is the cost if you're going to look at, you're giving so many drugs here? And then what do you do in the postoperative period? You carry all the 5 of them, you titrate one, decrease some, keep some on. What will happen if there is an analgesic gap? What do you want to give as a rescue analgesia? So these are the questions that need to be answered when you are proposing to use an opioid-free anesthesia. Just for removing one drug from the intraoperative period, you want to use such a big jargon here. So what happens here is that drugs also have their own drug interactions and side effects. So when you use multiple drugs, you need to be careful about their drug interactions. And also these adjuvants will be used in fixed dosage. That means it will be used in a particular dose without any titration for all the patients and according to the surgical needs. So we should really address what is the risk-benefit ratio of this, the opioid-free anesthesia. So friends, is it time to move forward, to move on from opioid-free strategies to opioid-sparing strategies, where of course it will look like this, where you have counseled the patient preoperatively, you decrease the preoperative opioid use. In the intraoperative period, you try and use a multimodal analgesia using locoregional blocks. In the postoperative period, again, you try and decrease the amount of opioid use, try and titrate together with multimodal analgesia and also regional anesthesia. If at all, the patient is discharged with some kind of opioid, during discharge, they have to be followed up very, very critically in the pain clinics, and they have to be taught about safe disposal of opioids in order to get into the crisis of opioid crisis or the opioid pandemic. Again, to summarize, therefore, friends, opioid-free anesthesia has limited evidence, is of questionable safety. There is a possibility of drug interactions. It is difficult to titrate to patients' requirements and to surgeries. It is resource intensive, and last but not the least, very, very costly, and the cost calculations have not been done yet. So opioid-free anesthesia, though feasible, is neither logical nor it is beneficial to the patient. And let us avoid making surgical patients pay with unnecessary suffering for the opioid prescribing sins of others. So this is how I rest my case. Thank you for a patient hearing.
Excellent presentation, Dr. You just told about the possibility of your RCT. The only thing that you mentioned.
Doc, your microphone is not, I can't hear you. It's echoing.
Hello.
Yeah, that's better.
Just to make your presentation, we have the possibility of your trial. The last one which published in the Psychology Chapter 21 is saying this was the one trial which compared
with the required sleep with the amitriptyline and with one clinical trial is also going on.
There's a lot of echo. I think there is something else on there. I'm not able to catch.
Please unmute your yes, ma'am. So please unmute yourself. Dr. Sri, unmute yourself.
There's too much of an echo. I'm not able to catch.
Just unmute yourself. Dr. No. Yes, ma'am.
There is a lot of echo actually.
You are very clear. Hello. Yes.
Yeah, if you can wait till the echo goes off, I'll be able to hear. Just you have to say slowly.
And now I'm concluding this.
It's very clear now. It's very, very clear now.
Okay, ma'am.
Yeah.
Yes,
So
Doctor. Okay, ma'am.
Thank you so much. Thank you so much. And I cannot agree more about what you said, that it has to be tailored to individual approaches. And since we anesthesiologists have been using opioids for a very long period of time, we need to be really continuing with our practices and maybe decrease the doses a bit, and use the practice of multimodal analgesia. Thank you very much for inviting me, and I really enjoyed being a part of this one.
Okay, thank you, ma'am. Thanks again. And conclude करना है? Okay, ma'am. Thank you.
Thank you.
So. इसको इसी साइड से था, उधर से नहीं लगा। नहीं करता।
Thank you, everyone. There were some technical glitches. I don't know how come it has been resolved when I am there in the dais or the podium. It has been resolved, but when our moderator was speaking, it was echoing so badly. There were some issues, but then again, finally, I think it was audible to you all, and at least you could have taken the message which actually our speakers would have conveyed. It was excellent, and the moderator has really played a very important role in actually deriving the conclusion for the topic. I'll like to invite Dr. Ashutosh Jha sir,
for felicitating our speakers as well as our chairperson or the moderator. So first of all, a token of appreciation and felicitation for Dr. Nitin. Please come up to the dais, and Dr. Ashutosh Jha, sir, please come up. Thank you. In fact, Dr. Srividya, ma'am, you are there. We have a memento for you also to felicitate. I don't know how will you collect it, but then again, if you, I would love if you come to Patna. In fact, give us the opportunity. If you are there, it will be handed over to you, or maybe Gautam Saha sir or somebody else from Jamshedpur sir, Sharad sir will be taking it back. Okay, Sharad sir will be taking it back. So I would ask Dr. Kishore Jhunjhunwala sir to please receive the memento on your behalf as well. It's actually your memento. Thank you, ma'am.
Thank you
It
so
will be
much.
handed over to
Would
handed
have
over to
loved to
Sharad
be
sir,
there, but some
and you can collect
unfortunate
it.
circumstances, yes.
ले लीजिए sir. Ma'am can at least see that it has been collected.
Yeah, I can see. Yes, yes. Sharad is there, no? So Sharad can bring it back to me. Yes.
Thank you. And now I'd like to request Dr. Ashutosh Jha sir to please hand over the moderator. Sir, this it's a token of appreciation for our moderator, Dr. Kishore Jhunjhunwala sir. In fact, he doesn't need any introduction. He is really a gem of a person with so much of knowledge, especially in the field of critical care. A big round of applause for Dr. Kishore Jhunjhunwala sir. Thank you.
Thank you for such a nice word and a good the way the conference is going on.
Thank you, sir. Thank you for the appreciation. In fact, we will quickly proceed on for our next ProCon session, and that is smartphones inside the operating room. And for this, I would like to invite our speaker, Dr. Gautam Saha sir from Bokaro. And for the con session, Dr. Arvind sir from IGMS Patna. Dr. Gautam Saha sir will be online. Will be online. Just check whether the sir is online there, and his presentation is already there in the in my pen drive. And just check sir is whether online or not. I have shared the link.
भाग जाता है। अरे ये तो लिंक पे भेज दीजिए।
भाई जल्दी आओ यार। अरे यार वहाँ किसी और को डालो ना मॉडरेटर। आ जाओ आ जाओ आ जाओ। Sir, please join, sir. Connection. Okay. Just try to join. If you will be there, it would be great. Then I'll be presenting. Sir, please do it fast, sir. Please. Okay, sir. Sorry for the delay. In fact, our moderator has not yet arrived. Yes, he is there. Thank you, Neeraj. Thank you so much for coming. And Dr. Gautam Saha sir is facing some technical glitches trying to connect. So he is trying to send us a pre-recorded presentation. In fact, one of the files which has been received already, actually it is just incomplete, and he will be connecting with us shortly. So I think I actually could not go for the con session right now, because unless the pros has been dealt with, I will not invite the con session, because let the pros come up. So sorry, sir, you'll have to wait a bit. Let Saha sir come up with the presentations. excuse me, with the due permission of our scientific chairman, sir, can we proceed on to the next session? By the time Dr. Gautam Saha sir has some issues regarding connection and he is even not able to send his pre-recorded PPT. So can we move on to the next session first? Okay, fine. Thank you. Thank you, sir. I hope the next session I have the speakers and ma'am is there. The next session was actually tackling the resistant microorganisms in the ICU. And for this, we have actually, this was an expert panel discussion. And in fact, the panelists have fortunately come over here and we are fortunate to have them. So I would like to invite Dr. Asif Ahmed sir and Dr. Pooja ma'am. Ma'am, please come up to the dais.
विशाल के बोलो ज्वाइन कर लिए विशाल के लगा आप बोल सकते हैं सर हेलो हेलो विशाल मैं जूम लिंक पे आ गया हूँ विशाल Hello, can you hear me? Hello? Full सुन दो बच्चा. Sound. Hello? Just a second now.
Sir, please unmute yourself. I think I have been able to unmute you. Please try to speak out.
Hello, good morning.
Yes, sir. You are now pretty audible, and you can
Can
go
I
on
speak?
for this session. Sir, just a brief introduction. In fact, you are basically from Bokaro General Hospital, and what I could get on your CV was that you are the head of intensivist, and you are actually in Bokaro General Hospital as the head of department of anesthesia as well. So welcome, sir. Welcome for the pro-con session. And your topic is you are speaking on smartphones issue, and you are here to deal with the pros session. And we have for the cons, Dr. Arvind Kumar from IGMS. Sir, please come up here. And for the moderator, we have with us Dr. Neeraj Kumar. He is assistant professor in AIMS Patna, and he is there in trauma and emergency. And he is one of the dynamic personalities, and he has so many publications to his credit. And he has very much skills about managing the as an anesthesiologist as well as an intensivist. So we would be honored to have him here as a moderator. Dr. Neeraj, please come up to the dais. I have given a just brief introduction about the speakers, so that we can save our time. And sir, please coordinate and get the topic started.
Thank you, sir. I think now we are ready for the start of this very important topic as well as session also, because we all know that these smartphones are now becoming a part and parcel of our everyday lives. So, welcome, Saha sir. Welcome.
Yes, sir. Good morning. Good morning, Neeraj. Good morning.
Yeah. And Arvind sir, please take your place. And just I will say a few words about before starting our consent pro. Just I will like to add a few things that why these smartphones has really emerged, and why it is now in a happening mode. Because we know that this telecommunication industry in 2010 they made this smartphone defined by these industries, and now these smartphones are becoming an integral part of our physician's life, not only as a personal and professional scheduling, but as well as for accessing medical information, as well as drug information, and randomly we can have various emails and all that. We are already aware of various types of operating system smartphones, like CPN one that was very initially used. After that, then Palm operating system has come, then Windows, and now we are using Android. 2007, the JESCI HC in anesthesia, they have published a report. What they have done, that they have included 40 anesthesiologists. And out of these 40 anesthesiologists, they have done a hand disinfection in all those, and among those anesthesiologists. And they have been asked for use their personal in-hospital mobile phones for a short phone calls. So you will be really amazed to know that out of this 40, 38 anesthesiologists have bacterial contamination. So what they have done next, that they have used their fixed mobile phones, and out of which 33 anesthesiologists out of 40 were having a bacterial contamination. So it was in late 2007. So you can understand that till now, no clear-cut guidelines is there how to use these smartphones. So now we are sure that from today's discussion, we can have some more ideas of it. So without wasting much time, I would like to welcome Arvind sir. And Dr. Arvind is an additional professor in anesthesia and critical care medicine at IGMS Patna. And sir will speak on cons part of using smartphone inside the operating room as well as in this. So before that, I would like to invite Prof. Sir. Sir is a joint director and head department of critical care from the Bokaro General Hospital. And before starting our sir, sir will speak on pro part of smartphones to be used in operating room as well as defense sector. Sir,
Good morning. Good morning. Am I audible? Am I audible?
Yeah, yes.
I won't be sharing the slide. I will just be speaking. Respected chairpersons, moderators, my dear colleagues, a very good morning to all of you. We are here to discuss a very burning topic and a very relevant topic in today's scenario, the role of smartphones inside the operation room. It is said that invention is a natural outcome of creative thinking. Let us go back for about 30 years when we are all in medical colleges. Subscriber trunk dial, STD and ISD, international telephone connections, they had become very popular. And it was a path-breaking thing. We didn't have to book a telephone calls. We could directly access the phone calls to whom we wish to talk. At that point of time, it was often discussed that a time might come when we can directly see the person to whom we are talking. And to put in layman's terms, we are talking about something called TV telephone. Yes, ladies and gentlemen, somebody at that point of time thought that there could be a situation where a device might be created where we can see the person over a long distance to whom we are talking. The outcome of this creative thinking was an invention called the smartphone. In 2010, the telecommunication industry described the smartphone as a device that offers the most advanced computing ability and connecting ability and having intelligence similar to personal computer while offering the capabilities of mobile phone, running robust operating system that provides platform for third-party application, having more processing power and memory, multiple connections such as Wi-Fi, Bluetooth, multimedia applications such as photos, media, music videos, and GPS functions. Right from the definition, we can understand why the smartphone is such a versatile instrument. As the definition suggests, the smartphone has a huge computing ability. It can compute a lot of data within a fraction of a second or few minutes. Connecting ability, we all know it. WhatsApp, Facebook. Multiple people can connect over the smartphone over a long distance on any part of the world. It has an inbuilt artificial intelligence whereby it reduces the use of manual use to the minimum. It is a miniaturized, it is mobile, and has got a multiple multimedia applications. Against this backdrop, because of these particular qualities, the smartphone has touched practically every walk of life, starting from a food seller to a scientist. Even we as perioperative physicians or anesthesiologists or intensivists, we are not immune to it. So let us come and see what are some of the benefits we have derived from the use of the smartphones. If we go into the details of the use of smartphones, it's a long one and a huge one, and it has got a myriad applications. In this brief time of 10 minutes, I have made a very modest effort to bring to the fore some of the essential applications which we are carrying out in day-to-day practice. Portable echocardiograph system for high-risk cardiac patients use smartphones attached to heart monitors to transmit heart rhythm data to the health providers. This way, it has helped in saving many lives and also alleviating the problems of many patients. There are applications in iPhone, which in devices to monitor oxygen saturation and other vital signs is available. So over a long distance, a physician can have access to the patient's current clinical status. Smartphone screen attached to USB device with an appropriate probe has been used as an ultrasound device, ultrasound monitoring device at the bedside, in the operation room theater, in the post-operative ward, or in the ICU. It's a big problem to keep the children calm, those who come for the operation theater, in the operation theater for an operation. The smartphone games and the various applications there has been used to calm the assuaged jittery nerves of the patients and the parents by of using the smartphones. Calculation of drug doses has become quite easy using smartphones, and scheduling and record keeping of the cases has also become quite easy. The smartphones have got a wide range of academic applications. Smartphone facilitates learning, treatment communication by capturing interesting diagnostic images or recording procedures. Clinicians can educate patients regarding prophylactic measures such as the management of smartphones, as we have seen in the pandemic. WhatsApp and other means were used using a smartphones to treat the COVID patients practically all over the world. Difficult airway videos and regional block techniques and fiber optic intubation technique videos provide a great academic support, as we have been seeing over the last 10 years. There are certain important emergency uses. If you are connected to the hospital information system, we can have a real-time and quick access to the investigation reports, CT scan, MRI, and we can download guidelines of CPR, difficult in airway, cannot intubate, cannot ventilation situation, as and when required in the operation room theater or in any emergency situation. Not to speak the inbuilt flashlight which is present. There have been occasions when the laryngoscope blades have been flayed, the flashlight of the smartphone has been used for intubation, and when there has been a power supply for a short while, the flashlight of the smartphone has been there to assist in the surgical procedure. Visualization and navigation by connecting to the arthroscope, live videos for acute alignment of joint replacement implant has been displayed. There are surgeons who have used smartphone apps to simulate a surgery before going for important complicated surgery, whereby yielding much better results. Ophthalmologists are using smartphones for visual acuity test. Airstrip OB is an app designed by the obstetricians to assess their electronic media records, real-time and historical waveform, fetal strep and material contraction pattern. Smartphone-based medical calculators for antibiotic dose calculation, especially for pediatric age group like MetMath and MetCal, have been proven to be exceptionally useful to the practicing clinician. Not to speak the least, there has been a documented report in many journals, especially British Journal of Anesthesia, the music therapy provided by smartphones to the patients have helped the patients a lot, thereby helping in stabilizing the vitals intraoperatively. But my worthy opponents have certain perceived concerns. Transmission of nosocomial infection into the operation room theater, electromagnetic interference by the smartphones to the instruments present in the operation room theater and as a distraction. Let me tell you, there are certain perceived guidelines to keep the smartphone at a regulated distance away from the operation theater equipment, whereby minimizing the electromagnetic interference. Non-touch devices have been developed, whereby where your operation inside the operation theater, your smartphones can be sterilized as and when required. And distraction, we can easily avoid distractions by keeping the smartphones away when we are completing the vital procedure. It's our self-control. People have flown aircraft, but the accidents have been there. We drive a car, accidents have been there. When we go to the cricket field or the football field, sports injury take place. But does that mean we should discontinue flying, we should discontinue driving, we discontinue playing? Certainly not. We have to always analyze the risk-benefit ratio before condemning a particular procedure, particular invention. Ladies and gentlemen, it is said that innovation distinguishes between a leader and a follower. Creativity is a habit, and the best creativity is the result of good work and good habit. Keeping these factors in mind, I would like to say that smartphone has been an innovation which has practically revolutionized our life and is going to do in the coming years to so. Thank you very much for a patient hearing, and happy Diwali.
Thank you, Prof. Previous rules of these smartphones are now part and parcel of our day-to-day activities. that in the intraoperative room what are also as well as in the So now, as we have discussed about the pros, now I will invite Dr. Arvind for discussing on the cons part of using that smartphone. Because yes, there are various distractions as well as learning applications might be getting reduced because if you are using a multitasking using these smartphones, obviously the problems may arise because yes, at one point of time you have too much of advantages using it. Apart from that, if you are using it as an advantageous form, obviously it has some disadvantages also on using the smartphone and most it has also broken infection or because there is no strict guidelines are there for using that smartphone, how to clean it and how to optimize it. So based on that, I think on spot.
Good morning to all of you. And thanks to organizing committee to give me opportunity to say something about the consequences of use of smartphone in operation theater. Consequences of use of smartphone in operation theater. Every technology has so many advantages and used both in outside the operating room and inside the operating room. In one hand, on the other hand, it has some disadvantages.
Hear you. Can't hear you.
Accident while chatting with other person. So it is the disadvantage of use of smartphone. Today, a smartphone has been incorporated in our life to such an extent that it is used in even in operation theater for both professional and personal matters. So now we come to our topics, the consequences of a smartphone in operation theater. This is the picture in operation theater, and imagine ourselves when we are on the operating room and the persons around you taking a selfie and giving order to someone to buy something and chatting with other person, then how would you feel in operating table? Now coming to the disadvantage, it is the source of infection in operating room. These devices are source of cross-contamination and can contribute to microbial contamination in operating room. In a study published in November 2013 in US, 1.7 million patients are affected by healthcare associated infections. And other publications shows multiple study confirmed that 90% of healthcare professional cell phones tested positive for bacteria, including MRSA and other microbes. Now, other study shows when taken culture from the smartphone shows that so many bacteria, even viruses and candida species
is found in their smartphone. In one study did by Jeske et al. Published in Anesthesia 2007, so studied on 40 doctors working in operating room using their in-personal mobile phone and a fixed phone in hospital, and found that 38% were found positive when using personal in-hospital phone and 33% found positive when using fixed phone. Brady et al. Showed that mobile devices used in healthcare settings could enter a high level of contamination, and also that cellular phone in the operating room, and believed that bacteria-laden devices could possibly cross contaminate the practitioner's hand. Now it concluded that the use of mobile phones may have serious hygiene consequences. Even cell phone manufacturers warn explicitly against using cleaning agents of a smartphone. So the hand hygiene should require for personnel working in operating room and equipment used by it. Till date, there are no clear-cut guidelines available that meet hospital standards to cleaning of smartphone. Now, second one is distraction. The problem has been referred to as distracted doctoring, in which healthcare personnel are focused on a screen and not the patient, including conducting personal business and assessing internet sites during surgical procedures in ICU and other critical units. If attention is switched between tasks, there is a measurable cost in response to time and decision accuracy. And adding phone conversation to other tasks like driving results in distraction, causes major accidents. Now the time to come to stick this sticker at the outside, at the door of operation theater, to please do not use mobile phone inside the operation theater. Smartphones are also affect cognitive performance and vigilance. Their use increases reaction time, reduces focus, and lowers performance of tasks needing mental concentration and decision making. Now, vigilance. Vigilance is defined as a state of readiness to detect and respond to a small changes occurring at random intervals in the environment. So, vigilance is crucial component in the performance of work, even in military surveillance, air traffic control, cockpit monitoring, and anesthesia. So, vigilance is the motto of American Society of Anesthesiologists. A man, Philip Stanhope, said to his son and advised the distraction that there is time enough for everything in the course of the day if you do but one thing at once. But there is no time enough in a year if you will do two things at a time. So mobile phones are the source of distraction for operating room anesthetists as well as the staff working in operating room. The use of mobile phone has been very well compared with sterile cockpit rules. What is sterile cockpit rules? The sterile cockpit rules said that no tasks are to be taken by the flight crew member during crucial phases of taxi like takeoff and landing in operation below 10,000 feet above the ground. A sterile cockpit environment should be established during critical phases of the operation, such as critical dissection and managing critical patients in ICU. Parker Pope established that cellular phones impact attentiveness and cause intentional blindness. In healthcare, even a small mistake can be proven fatal. A study published in May 2011 by Smith et al. And he reported that 55.6% of 439 perfusionists admitted that when they use cell phone during cardiopulmonary bypass, 7.3% admitted that there is negative impact on their performance, and 33.7% technician reported that distracted by cell phone use texting during surgery. However, 78.3% said that it also affects potentially significant safety risk of the patient. Westbrook et al. Found that distraction due to a smartphone was associated with 12.1% increase in procedural failure and 12.7% increase in clinical errors. Another study by McBride analysis indicate that cellular phones users were so engrossed in this activity that they were often unaware of their own misusage and might not realize that they were distracted. In one 2011 incident, a Texas anesthesiologist was accused of sending text messages and email while monitoring a patient. During that, he failed to observe the patient's oxygen saturation for close to 20 minutes, and she died in surgery. The woman's family sued the anesthesiologist. Peter Papakos, a professor of University of Rochester, said, once we get into or start using our cell phones, we separate ourselves from the reality of where we are. So it is self-evident that if you are staring a phone, you are not staring a monitor. Complications happen when a doctor at Manhattan's endoscopic clinic and reality attracted to national attention. During that snapped cell phone picture during an operation on a comedian John River, the surgery was throat surgery went body and ended up cutting off River's oxygen supply. She went into cardiac arrest and died September 4. According to federal investigation, we found that that they didn't directly linked to the doctor cell phone. Almaga reviewed a case where a medical resident forgot to stop an anticoagulant medication for a post-operative patient. The medical resident was distracted by text message she received on her cell phone, and the patient continued to receive anticoagulant for several days. That results in emergency open heart surgery. Noise is another problem when we are performing laryngoscopy, tracheal intubation, or during crucial surgery. The patient may be startled and experience unnecessary anxiety by a ringtone or vibration. Now coming to another disadvantage of smartphone is interfere with the medical equipment. Electromagnetic interference produced by a smartphone results in interference in operation theater equipment. A study showed in 2005 reported a 1.5% incidence of interference out of 500 tests and concluded that there was clinically significant interference. Incidence of medical devices such as infusion pump ventilators also affected by electromagnetic interference. A study reported a controlled laboratory test of 76 types of operating room and ICU equipment that 15% of equipment was affected by mobile devices signals. The safest option is 1 meter rule proposed by Ernick and Provish, which suggests restriction of mobile phones use to more than 1 meter from the equipment. Another problem of a smartphone in operation theater, it is ethical and legal concern. Healthcare delivery organizations and operating room personnel are responsible for security of patient confidentiality, data information, and privacy. Mobile phones with a camera facility can constitute a considerable risk for that. The risk can be identified as possible breach of medical confidentiality, intrusion into patient's private life, possible contravention of Data Protection Act 1998, and breach of patient confidentiality. Now, some guidelines produced by Association of Surgical Technologists and it use of mobile information technology in operating. Guideline 1 said that mobile devices must be properly cleaned and disinfected prior to being brought in the surgery department or critical care units. Guidelines 2 is personal mobile devices should only be used in healthcare delivery organization designated non-critical care areas by operating room personnel. Third one is operating room personnel should turn off mobile devices in the presence of critical care or life supported medical equipment to prevent interference with the functioning of the equipment. Fourth one is operating room personnel have the duty to responsibly use mobile information technology without violating the patient confidentiality, protected health information, and the state and federal patient privacy laws. Fifth one is operating room personnel should use email and smartphones in an efficient and professional manner to coordinate the effectiveness care of surgical patients. And sixth one is CST should continuing education regarding health insurance portability and accountability and regulations and risks associated with the use of mobile phones in operating room.
मास्टर खोलो देखिए मास्टर खोलो
Hello. Thank you so much, Dr. Arvind, for your excellent presentation on distraction part. And I must thank Gautam Saha sir also for speaking on the disadvantageous part of using this smartphone. And we are aware that we know that these smartphones are increasingly now it has been used day by day, and we must be aware that yes, it should be used in all those parts, not only in intensive care but also in operating room, as well as various wards also. There are various new apps that have been already created, and we all are using those medical apps like Medcal and UpToDate. These are the various advantages already. We have lots of books that what we can read on these smartphones, but yes, it has limitations that no doubt it distracts, it breaches the patient and the doctor's communication. And then, as what Dr. Arvind has already given few examples of that also. So I think the one thing that what I like most is to use that described cockpit rule. That is described cockpit rule. I think that all those cockpit airplane pilots use that. That why when you are your plane is taking off or landing, you should use that for the cockpit. And if any questions from the audience to be asked by Dr. Arvind or Gautam sir, I guess you can take one or two questions.
I have can I put forward my point?
Yeah.
1 minute. Hello, good morning. Can I put forward my point?
Yes.
I have a question.
Yeah.
Hello. Just as my learned colleague, he mentioned a couple of very important points. Sterile cockpit. He showed one photograph there. The surgeons taking a selfie there. Let me tell you, I have not seen an operation theater anywhere. It's a cartoon. where a surgeon or anesthesiologist is taking a selfie inside the operation theater. Number two, he has rightly mentioned the concept of sterile cockpit. There is also a concept of a sterile operation theater. We are not supposed to use the mobile phones routinely while a surgical procedure is going on. And to avoid the electromagnetic interference, there are certain rules that it should be kept at a certain distance away from the equipment used in the operation theater complex. And we use it is on a routine basis or also on an emergency basis, as and when required, at a certain distance from the operating theater site, operation site. So I think it is quite unfounded to say. And finally, equipments have been developed in this COVID pandemic, whereby the risk to obviate the nosocomial infection has been taken. There are risks, there are equipments which are sterilizing smartphones inside the operation theater, because we have to understand, after what we went through 1.5 years, and even when we are having this conversation right now, these devices, smartphone, iPhones and tablets, they are an inalienable part of our life now. We cannot live without it. So what is thing? Every development has its cons, and we have to see how we can minimize these cons and go ahead with the investigation, go ahead with our work with the new gadgets which we have at our disposal. Thank you very much.
True, sir. What you say is absolutely right, because if you are using some techno gadgets like these smartphones, obviously it has various advantages as well as some disadvantages. But that's why this debate was called for, so that we should at least have an idea about it, various distraction as well as some important advantages of using these smartphones inside the OR or inside the immune system. So if we have more questions, then we can move forward to the next session.
Thank you, sir. Thank you for the excellent debate. Yes. Thank you for the very good communication between the Prof session. In fact, I would like to thank Dr. Gautam Saha sir. In fact, thanks because he had some family issues and still he was able to connect with us with the all the glitches, technical glitches which he was facing initially. And it was very nice having an enlightened talk with you, sir. And accordingly, the concession which was delivered by Madam Speaker Arvind sir and Dr. Mishra, I would like to thank you so much for moderating the session. And that too, in the last moment, you have done a very good job. Now I'd like to call on Dr. Kunal Singh sir, Associate Professor from IGNS, to please present a token of appreciation to felicitate our speakers. And in fact, Gautam Saha sir is not here, but then again, Arvind sir is here. We would have loved if Gautam Saha sir was here, then it would have been great. But then again, sir, please come up and felicitate.
Thank you very much. Thank you very much. Thank you very much.
Thank you, sir. Now I would like to call memories are very, very important. Thank you, sir. Yes. Thank you so much for being with us. And now I'd like to call our chairperson. Please come up, sir. And Dr. Kunal, sir, please facilitate our moderator, Dr. Neeraj Kumar. A big round of applause for Dr. Neeraj. Thank you for moderating. Thank you, sir. So we now quickly move on to our next session, and actually it was basically a panel discussion, but because of some reasons we had to switch on to an expert talk. Then again, Finally, some of the speakers, they have come back, and we are fortunate enough to have them here, and they are physically present, so that's really great for us. And we have with us Dr. Pooja Sahai and Dr. Rishikesh Shah. Dr. Pooja Sahai, ma'am, is a clinical microbiologist and infectious disease specialist from Ranchi, whereas Dr. Rishikesh Shah is head of Dr. Rishikesh Shah is head intensivist at Ma Pyari in Super Specialty Hospital in Ranchi. Sorry, sir, I could not actually get your words. So it is Ma Pyari Super Specialty Hospital in Ranchi, where you are a head intensivist. And welcome, sir, to the session. And Dr. Pooja Sahai, ma'am, I welcome you to deal with the topic of prevalence of serious gram-negative bacteria in the ICU. Then this would be followed by Dr. Rishikesh Jha, who would be speaking on the treatment of MDR gram-negative bacteria in the ICU. And to moderate the session, we have our head with us, that is Dr. Asif Ahmed sir, who would be dealing with the tackling of the MDR organisms in the ICU. And he is the head of Department of Critical Care in EMS Jamshedpur. So I think sir has connected with us. Yes, sir. Welcome, sir. You are there. I can see you, and I hope I am audible to you, and everything is clear. So we have everything ready with us. So you will be given the opportunity after you have completed their talk. Thank you, sir.
Thank you very much. Good morning, all. Am I audible?
Please try to say. Yes, sir. You are pretty audible.
Okay. Thank you once again. And I think that's a great session that we'll be looking forward to. And just to brief up again before Dr. Pooja starts the presentation. So we are going to deal with the tackling or management of resistant microorganisms in the ICU in a day-to-day practice. And since all of us anesthesiologists are involved with critical care, so it's imperative that we should be very much aware of all these knowledge and the implications. So we have just broken up into three brief talks. So Dr. Pooja Sahai would be covering about the prevalence of the infection, the MDRs. That will be followed by management of these MDRs by Dr. Rishikesh Shah. And finally, I'll have a brief presentation where I'll be talking about the overall approach to handle the resistant microorganisms. So I think before, without wasting time, we proceed. Madam, Dr. Pooja, you can go ahead, please. Thank you.
Thank you, sir. Thank you so much, sir. So I'll be talking about serious gram-negative infections in ICU from a microbiological perspective. Let us start our talk with the impact of hospital-acquired infections in US. Now, US has very cleverly put the impact of hospital-acquired infections in economic terms, in monetary terms. They say US has said that the impact of nosocomial infections in US is $9.8 billion annually. But the 5 most common infections which they are dealing in their ICUs is central line associated bloodstream infections, followed by ventilator associated pneumonia, surgical site infections, C. diff infections associated with diarrhea, and catheter associated urinary tract infections. When we try to find a similar study in low and middle economic countries like India, we see that there is very limited data, and hence we could not get our hands onto any data which suggests the impact of hospital-acquired infections or nosocomial infections in economic terms. So let us see this study, which was done in 2007, which is a part of the EPIC-2 study. It is a one-day prospective point prevalence study. This study included 75 countries with around 14,400 patients from 1,265 ICUs across these 75 countries. The salient features were that out of this 1,265 ICUs, 137 ICUs were included from Asia. The lungs were the most commonly involved organ in ICU. 51% of all the patients were infected on the day of the study, and 62% of these patients were infected with gram-negative bacteria. Now, this is a recent study which has been published in 2021 itself, which was done in lower and middle income countries. And it states that the three most common infections in lower and middle income countries are ventilator associated pneumonia with a rate of around 11.3 per thousand ventilator days, sclapsy or central line associated bloodstream infection, rates being 4.1 per thousand central line days, followed by 40, which is catheter associated UTI. The rates are 3 per thousand catheter days. We need to know as we progress, how are we different from the Western world in terms of epidemiology of infections in our ICUs. So this is a study table taken from a study done in around 2009 by John Vincent. And if you see, they have compared the different type of organisms in Asian ICUs and Western ICUs. And we see that while in Western ICUs, the rate of gram-positive infections as well as gram-negative infections were almost similar, 50% and 58%. In Asian ICUs, the gram-negative bacteria was 74.5% and gram-positive was just 33%. More than double were infected by gram-negative bacteria in Asian ICUs. When we see the type of organisms which are seen in Asian ICUs, it is mostly Pseudomonas, followed by Klebsiella species, Acinetobacter species, and Acinetobacter species and E. coli. Whereas in the West, it was mainly Klebsiella and E. coli. So what are the factors? So what are the factors which cause ICU infections? There are several factors like severe clinical conditions of these patients being admitted in the ICU along with impaired immunity, increased risk of these patients of becoming infected with multiple procedures, use of invasive devices distorting the anatomical integrity in these patients, and of course, there's decades of overuse and misuse of antibiotics, inappropriate antibiotic therapy, overzealous antibiotic prescriptions by clinicians, which cause colonization pressure by resistant pathogens in these patients, and lapses in infection control practices. So if we see the prevalence of these microbiological isolates in ICU from different areas of India, we saw that different microorganisms or gram-negative bacilli in the world in low and middle economic countries, and now in Indian ICUs. These are the studies, 4 different studies taken from 4 different parts of India in the ICUs. We see again that gram-negative the types of microorganisms in these ICUs, most common Klebsiella, Pseudomonas, and Acinetobacter species. Coming on to the 3 most common serious ICU infections in Indian ICUs. This was a study which was done by Mishra et al. It was a device-associated nosocomial infection rates in ICUs of 7 Indian studies, which was a part of the international nosocomial infection. Followed by CLABSI or central line associated bloodstream infection, the rate being 7.92 per thousand device days, and the third most common was 40 or catheter associated UTI, the rate being 1.41 per thousand device days. The first and the most common ventilator associated pneumonia, we see that around 10 to 20% of patients on mechanical ventilation for longer than 48 hours will develop VAC. The incidence of VAC in Indian ICUs, as we have already seen, is around 10.46 per thousand ventilator days. And early VAC ranges from the most common organisms causing VAC in Indian Acinetobacter, we've all seen this, followed by Pseudomonas and Klebsiella. Now, why is it a cause of concern? It is a cause of concern because the Acinetobacter and the Klebsiella causing VAC are MDR and HDR. These are 2 studies. In the first study, we see that 66.7% of all Klebsiella causing ventilator-associated pneumonia in Indian ICUs were MDR, and 50% of these were extremely drug resistant. Whereas 33.3% of Acinetobacter species causing VAP were MDR, and 30% of these were extremely drug resistant. In another study which was done in Uttar Pradesh, it was seen that 73.1% of Pseudomonas aeruginosa were MDR. Yes, so most of these are either MDR or extremely drug resistant, as seen in these two slides. The second most common infection in Indian ICUs is central line associated bloodstream infections, and the rate is around 5 per 1,000 device days. This is a study which was done in Kokila Hospital in Mumbai, and it was from 2011 to 2018, and they found that the rate is around 5 per 1,000 device days. Profile of organisms which cause collapse in Indian ICUs, most commonly E. coli, Klebsiella, Pseudomonas, and Acinetobacter, as seen in various studies done across India. Now, this is a Moser study or the multi-center observational study to evaluate the epidemiology and resistant patterns of the ICU organisms causing collapse. And we see that 63.6% of Acinetobacter causing collapse are MDR, 50% of Klebsiella causing collapse are MDR, and 27.3% of Acinetobacter which were MDR caused 27.3% was the mortality caused by MDR Acinetobacter in these classifications. The third most common is catheter-associated urinary tract infections in Indian ICUs. Their rate ranges from 2 to 6.1 per 1,000 device days. Almost all microorganisms which are implicated in the causation of QARTI are either they come from patients' colonic or perineal flora, or from the hands of medical and paramedical personnel during the insertion of intravenous catheters, or due to improper handling of the collection system, or due to antimicrobial drug therapy. While protected for short-term catheterization, they carry the risk of selective colonization with multi-drug resistant organisms, such as Pseudomonas and other gram-negative bacilli, and they lead to outbreaks and infections with MDROs in the ICU. What are the profile of QARTI in India in different ICUs? Most common, E. coli, followed by Klebsiella, followed by Pseudomonas. Coming back to the Moser studies to see the resistance pattern of these organisms causing QARTI in ICU, we see that 60% of Pseudomonas causing QARTI in Indian ICUs are MDR, and 57.1% of Klebsiella causing QARTI in Indian ICUs are MDR. The mortality rate due to QARTI is not very significant in Indian ICUs. So where are we headed with the dawn of superbugs? We see that the emergence of MDR and XDR pathogens is often dedicated to excessive use of broad-spectrum antimicrobial agents, and this causes induction, selection, introduction, and dissemination of resistant strains among the ICU patients, leading to colonization and infection with MDRO organisms. This was a study which was done in low and middle economic countries from 2005 to 2018. The color key is given in the right hand side corner. What we need to be concerned about is only two colors, which is red and maroon. more than 50%, because this is India and this is where we are. Most of our organisms in ICU are resistant, more than 50% resistant to the most commonly prescribed antibiotics in ICU. This is where we stand. Now from extreme drug resistance, we are heading on to pan drug resistance. So this was one of a kind study which was done in Apollo Journey. Eight infected like PTR organisms, 5 were PTR or pan drug resistant Klebsiella. One was a case of Pseudomonas, 1 Enterobacter, and 1 Acinetobacter. 4 out of these 8 patients died. I think 50% mortality due to pan drug resistant. So this is the future as we all know. If we do not act now, WHO has said that there will be 10 million deaths by MDR organisms and infections alone by the year 2050, and the most commonly affected area will be Asia. So it is in our hands to work together with people and doctors of other specialties to curb MDR infections in our hands. Thank you.
Thank you, Dr. Pooja Sahai. Actually, a nice overview of what the status is all around the world, and it's no doubt it's a very dangerous proposition. So I would request maybe we can have a slight change. We can have the presentation on the approach, and Dr. Rishikesh Jha can take on the management and the questions at the end. So we can go ahead with the second presentation that was about an approach of how should we tackle the microorganisms. So I think we can play it online. Dr. Rishikesh? Yeah, good morning. So I welcome Dr. Rishikesh Jha, and it's going to talk about the treatment of MDRs, gram negative bacteria in ICU. I think that's a very important factor. Please go ahead, Dr. Rishikesh.
Thank you, Dr. Thank you, Dr. At the very outset, let me tell you that I've got a disclosure to make that I'm probably not the right person to speak for, because this domain is to be covered. Much of India data. We basically have more of India. We don't have any plants in our material, and it's a India is they don't have for us to map what laboratory work so that we get to identify early as to what is going to be the appropriate medication towards that. We are still in early days so far as that is concerned. The
because we need to hit early, hit hard, as we always been said. But what to exactly hit with? That's a concern. That's a major concern which we have yet to address. Yes, sir. Tackling with the MDR GMPs, we don't have much in the armamentarium because if you go by all the data that you have of the drugs that you actually possess, you have to use drugs like polymyxins or glycosides or tetracycline, or sometimes, although it may seem paradoxical, we use carbapenems. So each class of drug that we have is not a drug which actually suits your immediate needs, given the already adverse situation that you are in, that your patient is. So what are these drugs basically like the polymyxins, and polyester? These are detergents, and detergents for the bacteria, and they are just as harmful or as toxic as to us as they are to those bacteria, those drug-resistant bacteria. Especially so, this of concern is its nephrotoxicity. So, along with the nephrotoxicity, what we find as a limiting factor is its low lung penetration. So you can't actually be attaining the desired results with the dosages that are normally prescribed, because it is difficult for the VAPs to be treated at the recommended doses until you of course lower them. The other class, the aminoglycosides, they too have got the same profile of nephrotoxicity and poor lung penetration. Though not much of resistance has been found in the aminoglycoside, but it is on the rise. It is definitely rising. So one of the novel ones which has come up is plasmamycin. The plasmamycin has been approved by the FDA for complicated UTIs. But EMA, that is the European Medical Agency, that sometimes it provides room for you to prescribe it erroneously because it allows for its usage on terms of compassionate usage. So compassionate usage of these drugs, if you bring it in, then you are further putting these drugs in the hazard zone, because they'll grow resistant to these novel ones which are coming up right now. So compassionate use or off-label use should not be encouraged. We should be wary of that and try to limit drug prescriptions to what is exactly recommended by joint consensus committees, later the critical care bodies that they have been prescribed on a regular basis. Plasmamycin was actually to be used only for complicated UTIs, but of late it has also been started and used for complicated bloodstream infections with these MDR-GMPs. Tetracycline has been with us for a very long time. Tetracycline, one must remember, has got very poor urinary filtration. So you have to be again very cautious with its usage. Wherever you get MDR, that is Pseudomonas aeruginosa, which is inherently resistant to this drug. But if your microbiological backup is not good, they sometimes report it as sensitive. So you've got to be very cautious, knowing exactly what are the drugs which have got an inherent resistance, and the pathogens which have got inherent resistance to acute classes of drugs. So we need to be very specific about the drug usages there. Carbapenems, as I said, they have to be also used, although paradoxically in CI. because it was supposed that if you just tip over in a moderately sensitive kind of report that you get, if you tip over the MIC, this might actually start working in combination with another class such as maybe cholesterol or polymyxin. But whatever data that has come out of it, it has not been shown to be having any kind of a superiority. So again, for a country like ours, where we get drugs much later, like supposedly manufactured, I think how many of you have used it? But have you? Has anybody used it yet? Sir, have you? So we are pretty late into getting all these kind of some drugs. So we have to be again very cautious with the novel realize that are coming up. Just to name them, ceftriaxone, as I said, it's a novel, and it is recent development, and it's available and approved by FDA for the complicated intra-abdominal infections and perhaps. But this has been found to be actually effective more only for the CRDs and to some extent for the CRPs, but it has not really no role so far as the AMSI producing the CRDs are concerned, or even the graph. The other one that just come up is Campylobacter. This this group by all the complicated on the CRPs is second aspect trials, proven that this probably is the best drug for and in the tetracycline class, we talk of the tetracycline and that has come up is the iracycline. Iracycline is a pyrocycline and it's got a wonderful oral bioavailability. So this is going to be a game changer and it has been recently approved by FDA. This drug is about, but this also shares the same drawbacks that tetracycline has. So it is kind of ineffective for UTIs, complicated or uncomplicated ones, and also for pseudomonas. It doesn't work at this because it's kind of inherently resistant, much like tetracyclines. But the oral bioavailability of this makes it a fascinating drug because this is going to afford an oral switch over. Once you are done with the intravenous part, this can be used even orally. And this is supposed to be the drug for acidic factor, which is pretty common in our part of. Other than this, we have also got a novel one which is called as cefiderocol. This is unique because this drug, it's got a different mechanism of action altogether. It's cefiderocol. So what it basically does is it binds to the ferritin, and because of the upregulated ion channels during the course of activations, these cefiderocol channels they allow for the drug that is cefiderocol to enter into the bacterial cells easily and have an effective killing mechanism. There are measures and things which are being done to improve upon imipenem, the first of the carbapenems. So there's one new BLI which has come up, that is by the name of Renbactam. And the results of all the trials which have been conducted so far on the combination of Renbactam and Renbactam, they have been really good, and we expect this drug to be hitting the markets anytime. Similarly, we've got one more drug, the monobactam, which was Asturan. This again has been looked into properly because this class of drugs, they are effective against the NBLs. So Asturan along with Amitabactam is going to be one of those drugs which is going to be very effective against the PSBLs and the APC producers. Rifampicin and other drugs which have been used or are being used currently for double therapy, they haven't shown much of mortality benefits. So rifampicin in combination with any of the drugs is not encouraged anymore. So I just leave you with a couple of slides. So what are we presently with? On the CREs, that is carbapenem resistant ceftazidime avibactam, that is the preferred empirical choice when you have got APC and oxacarbapenem is reported locally by your labs, or you can use meropenem with valorbatam. Although in the lack of high evidence for both empirical and targeted treatment, a combination with an old drug such as colistin, polymyxin B, tigecycline, oral antihistamines, or fosfomycin, or you can even use plasmomycin. It could be considered in an attempt of delaying the emergence of resistance after having carefully balanced potential additional toxicity on a case-by-case basis. In case of resistance to PLBLIs, I mean, they have just come, yet a few cases of resistance have already been reported. In those cases, you have got to consider polymyxin-based or aminoglycoside-based combination with carbapenems, and you should consider concomitant administration of inhaled polymyxins or aminoglycosides when they are used intravenously for VAP. For the CRPs, ceftolozane and tazobactam, that's a preferred empirical choice in absence of concomitant risk of CRE. For empirical therapy, administer a second antipseudomonal agent. Although there is lack of high-level evidence for targeted therapy, combination of an old plus a novel agent could be considered for delaying the emergence of resistance. In case of resistance to novel BLBLI, consider polymyxins based on or aminoglycosides based with carbapenems and or fosfomycin and or rifampicin. Rifampicin, although is largely discouraged. Consider concomitant administration of inhaled polymyxins, aminoglycosides when you are dealing with a VAP. For CRAB, that is carbapenem-resistant Acinetobacter baumannii, administer polymyxin that as a backbone agent. Consider combination with old, that is carbapenems or old aminoglycosides or tigecycline, or novel agents such as plazo or pirava. Consider concomitant administration of inhaled polymyxin B or aminoglycosides when you are using it intravenously for water plant. So this is where we stand now. We have got very few drugs in our hand. What needs to be done to further arrest the resistance or development of resistance to the BLBLIs is to be discussed by Dr. Asif in this.
Thank you. Thank you very much, Dr. Rishikesh. I think very nice overview of the multi-drug resistant organisms that we are seeing in a day-to-day practice and how do we handle that. So we'll come close to the end of this talk, and I'll just put up a brief presentation. This will be about what is the approach to be adopted. You have already covered the key factors, Dr. Pooja Sahay and yourself, about the prevalence of microorganisms and what is the management to be done in terms of antibiotics. But beyond antibiotics, there are certain other strategies, and these become as a part of the whole protocol or procedure that you would say. So we can just have a quick overview of the total approach, and then we can open it up for question and answers. Dr. Vishal, we can go ahead with the presentation. Thank you.
And very good evening. Today we are going to discuss about data comparison microorganisms. And you all know the Liverpool ones are in RSK, the micromanagement of the GST of the estate to microorganisms, which includes E. coli. The risk factors are hospitalized for 48 hours, patients for 99. One may dangerous
fact, institute panel discussion. Yes, ma'am, please come up. Sir, please come up. Intro to Dr. Shikesh Masar. Thank you, sir. It was very nice talk, and very quickly I'll move on to the next session, which is actually one of the most important sessions of this CME, and that is the Ashok Gupta Memorial Oration part, that has topic of anesthesiologist beyond the pandemic. And for this, I would like to call upon our speaker, Dr. Ashok Kumar sir. In fact, this session is being chaired by two eminent personalities because the oration itself is of one of the biggest personalities of anesthesiology. And for this, I would like to call upon Dr. Ajay Kumar sir and Dr. Manoj Kumar sir, as well as Dr. Ajit Kumar sir. A big round of applause for three big shots of anesthesiologists. Dr. Ajit Kumar from Ranchi and Dr. Ajay Kumar from PMCH Patna. So this session will be chaired by three eminent personalities. The speaker will be introduced by our chairpersons, and so I'll quickly hand over the podium to the mic to our speaker, Dr. Ashok Kumar Sir. Sir, please.
We have great pleasure to chair the session of late Dr. Ashok Kumar Sir. For this oration, our speaker is Dr. Ashok Kumar, who is the HOD of the Katihar Medical College and professor and head. So we also organized IC Bihar Jharkhand Conference in 2013 at Katihar Medical College. A very eminent speaker, not in Bihar and Jharkhand, but also in India level. So I request Dr. Adil sir to kindly say few words about Ashok Gupta.
Very, very good show. And I wish all the
I really feel very glad to meet हमारे सर डॉक्टर अशोक गुप्ता से, जो कि सभी के लिए बहुत प्रिय है और खास करके आईएसए के लिए इतने
इमिनेंट पर्सनालिटी। और सबसे इम्पोर्टेंट चीज मैं उनके बारे में बता दूं, शायद यहाँ पर बहुत सारे पीजी हैं और जिनको इस चीज की जानकारी नहीं होगी। डॉक्टर अशोक गुप्ता आईएसए बिल्डिंग को इस्टेब्लिश किया है, जो आईएमए में, पटना के आईएमए में वो हॉल है जो आईएसए के नाम से है, सर का ही दिया हुआ है। इसलिए हम लोग उनको इस एनेस्थीसिया में, आईएसए में उनके योगदान को कभी भूल नहीं सकते। और इस विशेष रूप से क्योंकि उनका डेथ 2020 में ही हुआ है और हम लोग 2020 में कोई भी कॉन्फ्रेंस ऑर्गेनाइज नहीं किया था कोविड की वजह से। थैंक यू ऑल्सो आशुतोष झा सर, आप इसको स्वीकार किए इस ऑडिशन के लिए।
वेरी गुड आफ्टरनून। एक्चुअली हमारे और आपके बीच में कुछ चीजें कॉमन है। हम लोग सब एक कॉमन कॉज के लिए जमा होते हैं, एक ही विद्या हम लोग पढ़ रहे हैं। और डॉक्टर ए.के. गुप्ता सर और मेरे बीच में भी कुछ कॉमन है। हम दोनों ने एक ही कॉलेज से इंटरमीडिएट किया और नए लोगों को प्रमोट करने के लिए उनकी जो एक जद्दोजहद थी, हम लोग कटिहार यूनिवर्सिटी ब्रांच बनाने का सोच भी नहीं सकते थे। तो मिले बोले क्यों नहीं बनाते आप लोग। मैंने कहा सर ज्यादा नंबर नहीं, ऐसे करिए और कहीं कैसे देंगे नंबर और आप सिटी ब्रांच बना दीजिए। सो माय फ्रेंड्स, इट इज रियली अ प्रिविलेज टू प्रेजेंट in a oration named in such a pious soul, and it is a better privilege to connect to my extended family, the ISA Bihar Jharkhand, after such a long gap, such a period of dismay, such a period of sorrow and anxiety. Generally, you have been acknowledged in the society, not only the medical fraternity, whole society. लोग पहले तो उससे बड़े डॉक्टर लोग में जानते थे, अभी जानते तो नहीं। अब ये जानते कि नहीं, सिर्फ बेहोश नहीं करता, सीरियस पेशेंट को भी यही लोग देखता है। अरे वो सब तो दिखा के पुर्जा आए थे, वो सब काम नहीं करता। जब सीरियस हो गए तो यही लोग देखता। उन लोग का तो बंद हो जाता सामने में, 6 बजे के बाद ना कोई फोन उठाएगा ना कुछ करेगा, यही लोग देखता है। ये बहुत अच्छी बात है। हमेशा हर मुश्किल में एक कहते ना, व्हाट्सएप से कुछ ज्ञान मिलता है ना, हर मुसीबत में दिल दुखता बहुत है, लेकिन हर मुसीबत से दिल सीखता बहुत है। तो बिल्कुल ऐसा ही होता है किसी भी पैंडेमिक को। आपने सफर किया, कल से आज तक हम लोग पढ़ रहे हैं। मैं आप देखेंगे, मैं थोड़ा कोशिश करता हूँ कम से कम कॉन्फिडेंस में पढ़ा जाए, और इसमें और ज्यादा लोग होते तो और अच्छा लगता है। जो सेशन है, जो मुझे शिकायत भी है, खास करके पीजी से 100 पीजी होंगे, कम से कम उतने नहीं सेशन भरे रहेंगे। लेकिन मैं आपको बता दूंगा, बहुत ब्रिलियंट हो सकते हैं। आपके पास बहुत सारा मोबाइल है तो पूरी दुनिया आपके हाथ में है, बट माय फ्रेंड्स, the clinical skills they are not learned online. क्यों ऐसा होता है? आपका जो बच्चा 3 साल पीजी किया, 10 पेपर प्रेजेंट कर, 3 पब्लिकेशन कर दिया, वो जाके एमबीबीएस किए हुए एलसास ट्रेनिंग वाले के सामने फेल हो जाता बाजार में। बैठा हुआ, उसके पास काम नहीं, एलसास वाला घूम घूम के काम कर रहा। मैं नहीं, बेसिक लेवल कवर कर रहे हूँ अभी भी। बिल्कुल मैं एक रेजिडेंट की तरह काम करता हूँ अभी भी, और इसीलिए मैं बिल्कुल व्यावहारिक बातें बताता हूँ। So this is a blog about anesthesiology, very good blog. मैंने इसीलिए इसको select किया। We are multitasking. Why we at the forefront? अच्छाई में भी और बुराई में भी, sacrifice देने में भी और काम करने में भी, क्रेडिट लेने में भी हम लोग आगे रहे। So why we are at the forefront? We have unique interdisciplinary skill. देखिए बच्चे compete करके आते हैं, उसे कौन कहने किसी फर्स्ट चॉइस नहीं रहता, पहले दिन मुंह लटका हुआ रहता। वो मेडिसिन सोचा सही शुरू, मैं उसको बताता हूँ देखो ऐसी ब्रांच है जहां सब लोग सरेंडर कर देंगे, वहां तुम्हारा परफॉर्मेंस शुरू होगा। दैट इज एनेस्थीसिया। When all the people surrender, start. And fluidity and adaptability, पहली बात मैं सिखाता हूँ अपने बच्चों को। हमारे एक जो सबसे प्रिविलेज है यहाँ पर लगभग 3 जनरेशन है। अजीत सर मेरे टीचर रहे हुए हैं और डॉक्टर विशाल मेरा स्टूडेंट रहा हुआ है। ये सोचिए, आप मेरी खुशी को, मेरे जॉय को समझ सकते हैं। ये 3 जनरेशन के सामने प्रेजेंट करना इतने अच्छे आदमी के बारे में। फ्लूइडिटी एंड एडेप्टिबिलिटी, ऑलवेज बी एडेप्टिव। जो एनेस्थेटिस्ट है उसने कितना, जब आप प्रैक्टिस में आएंगे, खास करके फ्रीलांसिंग के बारे में बताऊं, कितने पेपर प्रेजेंट किए आपने, वो अच्छी बात है, आपका ज्ञान है तो बहुत अच्छी बात है। कितने लोगों से आप एडजस्ट कर सकते हैं, ये बहुत बड़ी बात है। We are going to learn about the application of robots in anesthesia, but we don't try to learn that we should not behave like robots when we work. That is the need of the day, my friends. Fluidity and adaptability. We are adapted to every situation. आपने देखा था बहुत अच्छा आया था कुछ दिन पहले न्यूज, एयरपोर्ट पर बचा दिया किसी को नहीं, और एक ऐसा धुरंधर एनेस्थेटिस्ट होगा। मैंने क्या वैसा कहा, मैंने कहा तो करना चाहिए कि मोटरसाइकिल पर पोर्टेबल वॉइस सक्शन और सिलेंडर वगैरह लाद करके और दरभंगा से चले गए 25 किलोमीटर दूर ऑपरेशन करवाने के लिए, चीजें करवा रहा होती है। सो दैट इज द फ्लूइडिटी एंड एडेप्टेबिलिटी ऑफ दिस फैसिलिटी। मैंने कहा तो ऐसा करना चाहिए, लेकिन अभी भी जो ट्रुथ है, जो इंडिया में ट्रुथ है कि हर जगह IIMS और एम्स नहीं है, पारस नहीं है। इवन नॉट ऑल द स्टेट मेडिकल, बहुत सुधरा है मेरे समय से, बहुत खुशी हुई। मैं भी दरभंगा एग्जाम देने गया था, अच्छे जगह एग्जाम है, लेकिन अभी भी दैट इज नॉट द होल ट्रूथ, दैट इज द हाफ ट्रूथ। बीइंग बिहेवियरली एटेन्यूएटेड एंड मोर वर्स, पहली चीज जो मैं सिखाता हूं, मैं खुद सुपरिटेंडेंट था, और अगर किसी बच्चे ने, मैं ड्यूटी दिया करता था बच्चों को, अगर आपने गलती से मुझे कह दिया कि सर फलनवा से मेरा नहीं पड़ता है, 100% मामले में आपको सारी ड्यूटी उसी का था दूंगा, एक भी ड्यूटी उससे हट के आपको नहीं मिलेगी। मैं कहता था जब तुम एक आदमी से बना के नहीं रख पाते हो, इतने पेशेंट्स आएंगे, मोर्टेलिटी होगी, डीओटी होगी, कैसे मैनेज करोगे? दैट इज द स्किल, द बेसिक। अभी हम लोग कराते हैं, डीओ का कोर्स कराते हैं, टीचर्स की भी क्लास लेते हैं, बच्चों की भी लेते हैं। सो दैट इज द बेसिक थिंग व्हिच इज रियली लैकिंग इन ए डॉक्टर। बहुत नॉलेज हो गया, लेकिन so you must be, you are very behaviorally talented and more must be used to working in all the conditions. and जब हम लोग आगे स्लाइड में आगे का सफर तय करेंगे, हम लोग देखेंगे कि ये जो चीज मैं कह रहा हूँ, this has all been proved by the research. Readily emerging knowledge from OT ICU wards, proficiency with patient trials and risk assessment. रिस्क असेसमेंट जितना अच्छा आप कर सकते हैं, वो कोई भी नहीं कर सकता। कई बार होता है कि फिजिशियन ने लिख दिया, नया सर्जन और एक ही केस पकड़ा, फिजिशियन ने लिख दिया रिस्क भी, लेकिन सर्जन छटपटा रहा कराने के बाद हम लोगों ने करा दिया, कुछ भी नहीं हुआ, खूब मजे से हंसते खेलते निकल गया। सो यू आर द बेस्ट असेसर ऑफ द रिस्क। जो भेजते भी है पीएससी के लिए फिजिशियंस के पास, उनके मन में भी सर्जन के बारे में बात रहता है कि फाइनली तो यही से फाइनल होना, कराएंगे या नहीं कराएंगे, लेकिन ये भेज देते हैं, देखते हैं क्या करते हैं। ओके, वाइड रेंज ऑफ प्रोसीजरल स्किल, कुछ भी चेस्ट ट्यूब डालना हो, आईवी लगाना हो, कभी जरूरत पड़ने से क्लिशोटोमी पर भी एक हाथ साफ कर दिया, बहुत देखे हुए हैं पहले से। कभी जरूरत पड़ने से वास करने के सर्जन के साथ में चले गए, वो सर में जानता हूं, भागलपुर में थे वो सीनियर, उनको इवन जो बेस्ट सर्जन्स थे वो जीबी में से बुलाते थे फंसने पर। सो वी हैव अ वाइड रेंज ऑफ प्रोसीजरल स्किल्स एंड यू यूनिकली पोजीशन to influence the resumption of, ये जो सब कुछ डिस्टर्ब हो गया, ये कैसे रिज्यूम होगा, इसके लिए सबसे अच्छे पोजीशन पर कोई है, दैट इज द एनेस्थीसियोलॉजिस्ट। तो बहुत लोग आपको 2030 में 50 में ले गए, मैं आपको 150 साल पीछे ले जाऊंगा। चलिए हम लोग 150 साल पीछे का सफर घूमते हुए तय करते हैं। ओके, जस्ट इमेजिन अबाउट द कोरोना पेंडेमिक। आप जानते हैं कोरोना से बहुत लोग मर जाते थे, डेथ टोल बहुत ज्यादा था, ओरिजिन इंडिया में हुआ। लेकिन मजे की बात यह है, आप एपिडेमियोलॉजी को सोचते हैं पीएसएम का सब्जेक्ट है, लेकिन एपिडेमियोलॉजी और एनेस्थेटिक्स के बीच में ऐसा रिलेशन मुझे मिला एक टॉक तैयार करने में। आई वाज सरप्राइज्ड। जॉन स्नो इज कंसीडर्ड एज द फादर ऑफ एपिडेमियोलॉजी। व्हेन द कोरोना पेंडेमिक अकर्ड, तो सब लोग ये मियास्मा थ्योरी मानते थे दैट इट इज ड्यू टू डिकम्पोज्ड बॉडीज। ही रिजेक्टेड। हम लोग हमेशा से रिवॉल्यूशनरी रहे, जो चला हुआ चीज है उससे कुछ अलग करने का एनेस्थेटिक्स को हमेशा रहता, कुछ ना कुछ। आप देखेंगे एक ऐसा स्वभाव में रहता आपका कि आप किसी जगह घुसे, किसी जगह घुसेगा आप देखेंगे सब कुछ जो नॉर्मल चल रहा है आपके नजर में नहीं जाएगा, जो नॉर्मल चल रहा है नजर में तुरंत आता है। एंड दैट इज द कैरेक्टर ऑफ एन एनेस्थेसियोलॉजिस्ट। उन्होंने क्या किया, सारा वाटर कंपनी को चेक किया और उन्होंने खोज के निकाला किस वाटर कंपनी से, किस टैप से, किस टैंक से कोलेरा का बैक्टीरिया आ रहा है। He traced it and this was the foundation of contact tracing in isolation. This was the foundation and modern pandemic has used these ideas from Stone. Second was a polio epidemic. हर साल ये हॉरर मूवी की तरह आता था और कुछ को लेकर के कुछ को डिसेबल करके चला जाता था। And that time it was thought by that it is in wild coated banana or stray cats, swimming pool, theater सब। अभी आप अगर सोचते हैं कि आप बहुत खतरनाक ऐसे पास कर रहे हैं तो आप बिल्कुल सही नहीं, ऐसे भी खतरनाक दुनिया ने देखा है। बट जीवन है, जीवन है तो विनाश पर ग्रो कर जाता है, इवन मर जाता बॉडी उसमें से भी फंगस ग्रो कर जाता है, करता वो भी तो जीवन ही है। तो जीवन विनाश से ग्रो करता है। सो ऑलवेज बी वेरी पॉजिटिव एंड ऑप्टिमिस्टिक। सारे बच्चों को वो ले लेते थे, पोलियो होता था और सेंटोरियम में माँ बाप से अलग रखा जाता और माँ बाप नहीं मिल सकते। अगर आप कभी सोचते हैं कि आइसोलेशन सिर्फ अभी हुआ, ये पहले भी होता था। एंड उस समय देखिए, उस डिस्पेयर के टाइम में सी द इन्वेंशन बाय द फिजियोलॉजिस्ट। पहले नेगेटिव प्रेशर वेंटिलेशन पॉपुलर था। Woodell just found out that IPPV, the polio patients do well under IPPV. We John Ibsen, he brought the concept of intensive care. उन्होंने क्या किया, देखा कि नहीं वो कुछ पेशेंट वहाँ, कुछ पेशेंट वहाँ, कुछ वहाँ पेशेंट रख रहे, वहाँ भी मर रहा, वहाँ भी मर रहा। उन्होंने सोचा अच्छा थोड़ा ईज कर दे इस चीजों को। ढेर सारा पेशेंट, ढेर सारे सिस्टर्स और कुछ डॉक्टरों को साथ में रखा। And he thought that the mortality decreased from 90% to 25%. And my friends, this was the evolvement of intensive and critical care medicine. तो देखिए कैसे out of a very disastrous situation, how we came out with a good thing. That is the beauty of life. And John Sovereigns, उन्होंने देखा कि नहीं वो कुछ चक्कर जरूर है इसमें, acidity alkalinity का. And he invented the blood test analyzer and Henry Rubin made the embu, जो popular हमारे पास अभी हमारे हाथ में armamentarian में, that was involved during the 1952 US polio epidemic. And third was the HIV pandemic. हम लोग शायद उस समय एक 2005 का ठीक है, इनिशियल स्टेज के प्रैक्टिस में हम लोग थे और बहुत डर लगता था, पता नहीं कौन पेशेंट कर लेगा। एंड करेंटली इतने लोग हैं एंड दिस, इसके पहले सारा रीयूज था। मैंने अपने सर से एक बार पूछा था कि सर इंग्लैंड में तो पेन सेफ्टी अलग अलग होता, बोले ना ना उतना पैसा किसी के पास नहीं है, अभी अलग अलग कुछ नहीं होता, वहां भी अभी पेन सेफ्टी बार-बार यूज होता है। तो मोस्टली वी वर्क वेयर हैंडेड एंड रीयूज्ड ऑल द थिंग्स। एंड दिस HIV/AIDS पैंडेमिक, इट taught us double gloving, eye protection, proper SAR disposal practices and proper waste disposal practices. And we just see the results of this practices. अगर लगता है कि नहीं रहेगा सब फालतू है, हाथ धोना, ये धोना, वो धोना, तो see the results. Top 2.2 से वो घट के 2.2 से घट के वो 1.6 मिलियन हो गया the death toll. Next was the SARS, MERS, Ebola, swine flu and Zika. ये सब आया and जब ये इंफेक्शन देखा, the editorial in the PJ it quoted our current infection control practices may have been adequate in past. पहले ठीक था, लोग बैलगाड़ी से भी चले जाते थे, but is not adequate at least in context of SARS. And then we had an impetus to develop the PPE, the masks, and regularly we made it the practice to double gloving. सब कुछ को हमने अपने जीवन में उतारा and we saw that even these patients, उसके पहले के प्रैक्टिस को हम लोग समझे तो उसको कोई भी केयर नहीं करता था। The feeling of abandonment, first phase, second phase जो हुआ, first thing was the feeling of abandonment and I think कि ये जो कोविड आया था, हर एनेस्थेसिस्ट, हर डॉक्टर जरूर डरवाए से हम लोग 4 मेंबर अपने परिवार में हैं। My son is a physician. He works at Mumbai. वो वहां से फोन करता था, नहीं आप सबसे सीनियर है, ये क्या तरीका है, कटिहार पुणे में कहीं भर्ती नहीं होगा पेशेंट, क्यों, आप स्टार्ट करिए कहीं भी स्टार्ट करिए, लीड करिए, बीमार हो जाइए, कोई बात नहीं, मृत्यु होगा तो मृत्यु होगी, लेकिन आप ऐसे नहीं कर सकते, एकदम गलत कर रहे हैं। He suffered. He worked in a big COVID hospital and he suffered from COVID. And just imagine the stress. कोई गाड़ी नहीं चल रही, अपनी गाड़ी से नहीं जा सकते, फ्लाइट नहीं चल रही है, आप सिर्फ वीडियो कॉल से अपने बच्चे को देख सकते हैं। सो वी ऑल सफर। और जब घर में आए तो मैडम चिल्लाती थी कि नहीं सबसे मजबूत तुम ही हो, सब जवान लोगों को प्रैक्टिस कर दो। मैंने एक भी प्रैक्टिस नहीं, प्रैक्टिस भी नहीं, हॉस्पिटल में नहीं, जहां जो काम हुआ सब कराया। सो वी दिस डिजीज ऑफ कंट्रास्टेड एंड कॉन्फ्लिक्ट, एक चीज आज प्रूव हुई और कल वो चीज डिस्प्रूव हो गई, चलता रहा। बट क्या हम लोग सोचते थे, ये रियल बात है, the exposure risk of anesthesia is high to very high, and our frontline workers household had a 1.8-fold increased risk. But reality is that incidence of COVID-19 among the healthcare workers is very low, especially the ICU workers, especially you, because you are addicted to act smart. आप जानते हैं कि झंझट से कैसे बचा डाल, you are addicted to hand washing, you are, और एक और इंटरेस्टिंग इसमें फाइंडिंग था, मैं बहुत सारी स्टडी देख रहा था कि the infection rate of female healthcare workers was low. इस पर मैं एक डिस्कशन देख रहा था, उसमें उन्होंने कहा कि in India especially they are accustomed to use hand washing and everything due to their kitchen practices, और इसलिए वहां पर वो कम है। एंड इट वाज ट्रू, मैंने अपने डिपार्टमेंट में देखा दैट मोस्ट ऑफ देम कंट्रैक्टेड द इन्फेक्शन आउटसाइड। अंदर तक तो ठीक रहा, बाहर में खाने पीने लगे, गपशप करने लगे, कहीं चले गए, थोड़ी अनसेफ प्रैक्टिस हो गई। एंड दे हैड अ वेरी लो रेट ऑफ ICU एडमिशन, मे बी ड्यू टू लो डोज ऑफ वायरस इनोकुलेशन एंड लोअर प्रिवेलेंस ऑफ इन्फेक्शन and 20% lower mortality rates than the wider population, maybe due to lower viral dose, maybe due to adhering to the good practices, and these are the proof data. जाहिर आपने काम किया था, कुछ न कुछ मिलना चाहिए, and you see a lot of media appreciation. This is from print. How overburdened anesthesiologists are silently leading India's COVID बेटर। कहीं पर और सोसाइटी में भी जहां पर की कोई जानता नहीं था, आपको जानता नहीं था, लोग पड़ोसी वाले डॉक्टर मानते, तभी ये मानते, कब सब इतना मानते हैं कि ये लोग गंभीर पेशेंट्स को देखने वाले डॉक्टर होते हैं। सो द मोस्ट एंड लीस्ट ट्रस्टेड पीपल इन वर्ल्ड, इसमें भी किसी ने निकाल दिया कि देखिए 46% इसका मतलब आप पर भरोसा नहीं करते, नेगेटिव खोजने वाले इसमें भी खोज रहे हैं, ठीक इस स्टडी में भी। बट एटलीस्ट इतने में तो सरकार बन जाती है, तो एटलीस्ट द 54% पीपल rely on you. That is a good and heartening thing. So the controversy is still going. There was a myth that it was a system collapse, total lack of resources. Media ने ऐसे ही प्रचारित किया इसको. I don't agree. It was actually an underutilization, misallocation, and improper utilization of resources. क्या है कि सबको खांसी छींक होने से भी पटना एमसी जाना है, और जब पटना एमसी जाना है तो अहमदाबाद पीएससी में 50 सिलेंडर क्या कर रहा है, कोई मतलब नहीं है। We have made a parallel systems. We have made islands among the brethren. ये तो वो एम्स के डॉक्टर हैं, वो बिना प्रैक्टिस वाले, वो प्रैक्टिस वाले, वो स्टेट्स के हैं, वो कॉर्पोरेट्स के हैं, और वो इंडिविजुअल वेंचर वाले हैं। So there are a lot of examples to work. अब मैं आपको सेवन हिल्स हॉस्पिटल का एग्जांपल देता हूँ। It was a sick hospital. मैंने काफी पढ़ा उस केस स्टडी को। It was a sick hospital, बंद हो गया था वो, गवर्नमेंट ने उसको फंड किया, और अब सेवन हिल्स का परफॉर्मेंस सबको पता होगा का क्या परफॉर्मेंस ने किया। मेरा लड़का जहाँ काम करता है, क्या क्या उसने, म्युनिसिपैलिटी ने एग्रीमेंट कर लिया बिल्कुल प्राइवेट मेडिकल कॉलेज के मैनेजमेंट से, रिटर्न एग्रीमेंट, रजिस्टर्ड एग्रीमेंट कर दिया, और रायगढ़ एडमिनिस्ट्रेशन ने भी एग्रीमेंट कर लिया, हम आपको 60 वेंटिलेटर देंगे, और पर एमडी जो है 1 लाख रुपया भी देंगे आपको, कितना ड्यूटी में लगेगा। एंड दे मैनेज 200-300 कोविड बेड्स 100 बेड ICU, 100 बेड ICU, 50 बेड ICU, कुछ भी कर दिया. It means that we have learned, if these hands are joined together, if we share the resources, your colleague is not your competitor. अब जब आप देखिए, इससे कभी मैंने सवाल उठाया था कि जब सबको ऑक्सीजन प्लांट लगाना है, always try to share the resources, try to share the knowledge, try to share the resources, and try to help out your colleagues. That is the demand of the day. That is the learning from this pandemic. जहां जहां हमने ऐसे हाथ मिला, भरतपुर में एक प्राइवेट हॉस्पिटल को दे दिया डीएम ने, हंगामा मच गया. अरे उसको चूहे को कर रहे थे वेंटिलेटर को, एक डिस्ट्रिक्ट हॉस्पिटल में 40 वेंटिलेटर क्या करेगा? कौन डॉक्टर आपके पास है वहां, वो पेशेंट ले ही नहीं रहा, 40 वेंटिलेटर क्या करेगा? प्राइवेट को दिया, पैसा ही देने से ही कोई जान तो बची. नहीं तो उसके पहले क्या था, कहीं कोई बेड खाली नहीं है. I have my own hospital at Patna, and Dr. Kishore was saying, and I am just very sorry that I could not admit more than 20% of the recommendation. जितने मेरे पास फोन आए, मैं 20% जाने भर्ती करा ही नहीं पा, बेड नहीं भर्ती खाली मिले. So one thing which we have learned, that we learn to share the resources, share the workforce, and because delayed medical help and overcrowding, क्या हुआ? सारे लोग ठीक होने पर भी एक जगह जाके जमा हो गए, कहां से बेड मिलेगा? जादू तो होगा नहीं. That led to so many deaths. और डेथ से भी इंपॉर्टेंट इसमें ये था, nobody should feel abandoned. नहीं, कहीं बेड नहीं है, एम्बुलेंस में मेरा पेशेंट भर गया. अरे वो भरता तब भी, लेकिन एटलीस्ट आप उसको भर्ती करके बेड पर डाल देते. हमने शुरू किया कटिहार में, बहुत लेट. मैं कोई कमांडिंग पोजीशन में नहीं हूँ. हमने डिप्टी सीएम के कहने पर, वहां के डीएम से, कटिहार डीएम के कहने पर, डिप्टी सीएम के कहने पर, हमने भी स्टार्टेड इट एट सदर हॉस्पिटल. एंड यू विल बी सरप्राइज्ड. जैसे आप सोचते हैं छोटे जगह पे बहुत सारे बच्चे करते हैं कि सर बहुत रिस्क होता. मैं कहता था, जो लोकल लोग रहते हैं, 4 मुस्टंडे 10 मुस्टंडे उनके खड़े, मैं सीधा कहता था कि देखो ये जो बिल्डिंग है ये 2008 से है और ये कभी आज तक खुली नहीं थी. और जैसे तुम्हारा बाप अंदर है, मेरे भी बच्चे अंदर है, तो ये एक बराबर मेरे भी पीजी से अंदर में. और 2008 से बिल्डिंग कभी नहीं खुली थी. आज ये बिल्डिंग स्टार्ट हुई है. कोशिश करो ये बंद नहीं होगा. तुम्हारा प्रेजेंस हमारे डॉक्टर्स को संबल देने वाला होना चाहिए. मैं 24 घंटे तो नहीं रहता हूँ, मैं आता हूँ जाता हूँ, आई कनेक्ट वर्चुअली. दैट वाज द रोल. पता नहीं हमने अपना अच्छे से किया कि नहीं. एक बहुत अच्छी बात है कि सीनियर डॉक्टर्स का जो इन्फेक्शन रेट इंडिया में 0.5% रहा और यूरोप में बहुत ज्यादा रहा. ठीक है, ये तो लगता है खुश होने वाली बात है, लेकिन इसमें बहुत सारे निहितार्थ हैं जो घर जाकर के हम लोग अपना एक्सप्लेन करें कि सीनियर डॉक्टर का इन्फेक्शन होने का रेट खुशी की बात लगती है, लेकिन इतना कम क्यों रहा? क्या हमने अपना रोल पूरा किया? आप अगर 50-60 के हैं, डायबिटीज है, हाइपरटेंसिव है, तो जरूरी नहीं कि आप कोरोना वार्ड में जाए. लेकिन जब आपका बच्चा पीपी पहन रहा है, आप शीशे से देख सकते हैं. ऐसा नहीं कि आप बिल्कुल ही जाए नहीं, आप कोई काम नहीं करें और एक इंटर्न को भेज दें उसमें. दैट इज नॉट द वे. आई डोंट एग्री. एटलीस्ट आई डोंट एग्री. मैं कहता हूँ, हमेशा मैंने स्टूडेंट्स को कहा था कि मेरे टॉक्स थोड़ा कंफ्लिक्ट भी इनवाइट करते हैं, एंड आई लाइक दैट. दैट आई डोंट एग्री. मैं बता रहा हूँ, बहुत सारे हॉस्पिटल्स में the senior people, they even don't enter the building, the premises. That is not fair. आप नहीं जाए अंदर. और उल्टे गवर्नमेंट जॉब में क्या हुआ? They put the people with heart surgery, with diabetes, with hypertension, age 64, कि सब आपको क्वारंटाइन सेंटर देखना है. और डेथ हो गई. डॉक्टर उद्धार थे, डेथ हो गई उनकी कटिहार में. वेरी सॉरी. ये नहीं करने का है. अब आप जैसे बहुत बार हम लोग बात करते थे कि आदमी कुछ नहीं, एक आदमी बहुत कुछ कर सकता है, तो कमांड में हो. एटलीस्ट मैं रहता, मैंने अपने मैनेजमेंट को वहां भी कहा था, डीएम से भी बात हुई, मैंने साफ कहा कि अगर जरा भी कमी हुई एक्ट वर्स में बंद करूंगा. अगर पीपीए किसी भी चीज की कमी हुई मैं तुरंत बंद करूंगा. मैं गवर्नमेंट जॉब में नहीं हूँ, मैं समाज सेवा सोच के कर रहा हूँ. अगर कोई कमी हुई मैं तुरंत बंद करूंगा. सर्जन डरते थे, मैंने कहा नहीं, मैं सीधा उनको फोन करूंगा. दिक्कत है तो मैं सीधे डीएम को फोन करूंगा. आपकी नौकरी होगी, मेरी नौकरी नहीं है, तो सीधी बात है. बट इट इज वेरी हार्डली एक एक चीज, एक एक ड्रग उन्होंने अवेलेबल कराया कटिहार में। बहुत अच्छा एडमिनिस्ट्रेशन ने भी कहीं कहीं काम किया, एक एक चीज अवेलेबल कराया, कोई कमी नहीं आपको, ना पीपी कमी, कोई चीज कमी नहीं जब हम लोगों ने किया। सो इट वाज नॉट अ सिस्टम कोलैप्स, इट वाज एन अंडर यूटिलाइजेशन। 50 सिलेंडर पीएससी में पड़ा हुआ, वहां पर देना था, थोड़ा ऑक्सीजन लगा देता, उसको आने की जरूरत नहीं पड़ती, वहां नहीं रहा, वो सीधा यहाँ आ गया और यहाँ नहीं। इट वाज अंडर यूटिलाइजेशन, मिस एलोकेशन, लैक ऑफ। लेकिन सेकेंड वेव तक में हम लोगों ने बहुत कुछ सीखा, दैट इज द गुड थिंग। सो मेनी टाइम्स द एक थिंग, मैंने बहुत सारे ये पेपर प्रेजेंट करने के पहले मैंने बहुत सारे पीजी से बात की, दूर दूर बहुत जगह, जो बच्चे जो मेरे कॉन्टैक्ट में, एंड दिस ये उर्दू लैंग्वेज है। Many times the real workers remained a faceless entity and worked without proper leadership. पता नहीं 30 बच्चे इन्फेक्ट हो जाते हैं मध्य प्रदेश में। कौन इन्फेक्ट होता है? इंटर्न इन्फेक्ट हो जाता है। वो तो नाक से मास्क हमेशा छूता है, ओटी में जाता है तो कपड़ा लगता ठीक करने लगता है, कौन खाता है उसको? कैसे भेज देंगे हम लोग बिना कोई ट्रेनिंग के, बिना कोई वर्कशॉप के? उसको कैसे भेज सकते हैं वार्ड में? दैट इज नॉट प्रॉपर। सो एंड ऑल्सो the real workers who out at the, ठीक है, ये मैं मानता हूँ लड़े सिपाही नाम कोतवाल का चलता आ रहा सब दिन से, but you should acknowledge their work। सब कुछ उनको डाल दिया आपने, अपने उसका पीजी डिले कर लिया, एग्जाम नहीं दिया, बेचारा पढ़ ही नहीं पाया 1.5-2 साल को, अपने मार्क्स भी खराब दे दिए, जीवन भर के लिए उसको डैमेज कर दिया। दैट आई डोंट लाइक। मैंने मेरे यहाँ आए थे मौलाना आजाद के एग्जामिनर्स, मैनेजमेंट ने बुलाया था, लेकिन मैं बिल्कुल अड़ गया, नहीं इधर तो होना ही होना है। मैं अड़ गया, मैं ऑफिस से नहीं कर रहा हूँ, मैंने कहा नहीं, हमने उनसे क्या काम लिया और हमने कितना मदद किया उनको? फालतू फालतू जगह पे भेज करके हम लोग क्वारंटाइन सेंटर चलाते रहे और हम लोग ये कराते रहे, और लास्ट में उनको बेसहारा मैं नहीं छोड़ सकता, इसमें नौकरी रहे या चाहे कोई बात नहीं, लेकिन मैं छोड़ नहीं सकता पे। सो दैट इज द थिंग दैट यू ऑलवेज स्टैंड स्ट्रांगली बिहाइंड योर फ्रंटलाइन वर्कर्स। कभी किसी बच्चे को ये नहीं टारगेट फेसलेस एंटिटी, ये मेरे बेटे का टर्न है, उसने कहा कि नहीं दिस इज वेरी बैड। जो फ्रंट लाइन वर्कर थे, आप ठीक है, आप नहीं जाएंगे अंदर, लेकिन जो बच्चा आपका बीमार पड़ गया, कोविड में भर्ती हो गया, एक डॉक्टर, आप एक वीडियो कॉल करके उससे बात कर सकते हैं, उसके पेरेंट्स से बात कर सकते हैं। नहीं आपका बच्चा ठीक है, नहीं आजकल एक बच्चा होता है, किसी को दो बच्चा होता है। आप उस पेरेंट्स के बारे में सोचिए जो 4000 किलोमीटर दूर बैठा हुआ है और बच्चा उसका कोविड में भर्ती काम करने के चलते। तो देयर यू ओ ए ड्यूटी, उससे ही नहीं, वहां पर आपको प्रोफेसर नहीं बनना है, छोटी और रजिस्ट्रेटर नहीं बनना, वो आप एक बाप बन के, एक माँ बन के देखिए कि आपको कैसा लगता। सो दैट इज द लेसन फ्रॉम द पेंडेमिक दैट वी नीड, इवन द सीनियर्स, we need a lot of behavioral changes, we need a lot of, but we can do good things, enhanced infrastructure up to grassroots level। आज कटिहार में मनिहारी सब डिवीजन में भी ऑक्सीजन प्लांट है, हमने खरीदवाया, तो मनिहारी और बारसोई सब हॉस्पिटल में भी बैकअप है, सिलेंडर्स तो है ही, पाइपलाइन कनेक्शन है। दैट इज अ वेरी गुड आउटकम ऑफ द better recognition and perception in the society for anesthesiologists, greater team concept and blended learning। टीम कॉन्सेप्ट है, सब बच्चों के साथ मिलकर काम करना हम लोग पहले भी जानते थे, अभी हमने और अच्छा सीखा। ब्लेंडेड लर्निंग मींस समथिंग ऑनलाइन एंड समथिंग ऑफलाइन। जैसे पहले जो प्रॉब्लम होती थी पीजी टीचिंग में आपको कि सबका प्रैक्टिस का समय रहता है, टीचर्स भागना चाहते हैं, अभी आप ये कर सकते हैं, यू ट्राई ए फ्लिप क्लासरूम, यू गिव द लेक्चर्स, पहले देखिए भेज दीजिए, दूसरे दिन जब आता है जो आधा घंटा प्रेजेंटेशन से बड़ा, देन टू द डिस्कशन। तो ये ब्लेंडेड लर्निंग से बहुत लोग सोचते हैं कि पढ़ाई बहुत इफेक्टिव हुई। यू आल्सो मे टेक द एडवांटेज ऑफ दिस ब्लेंडेड लर्निंग, रीच अवेलेबिलिटी ऑफ गैजेट्स एज वेल एज इंप्रूव कांसेप्ट। अब हम लोग सब कुछ अच्छा समझ सकते हैं, चैपेंसी क्या होता है, कंसिडर कोई पूछता नहीं था, स्टॉल में कोना में नहीं रखा रहता था, अब हर आदमी खोज रहा। So these are achievements, these all gadgets are achievements of this pandemic। Clinical research redirection and optimization with a touch of skepticism। skepticism का मतलब होता है संदेहवाद। एक चीज मैंने कहा और तुरंत दूसरे ने संदेह कर देना, ना मुझे तो नहीं लग रहा, दूसरे दिन दूसरा पेपर निकल गया। इन सब तरह का पेपर है, इंडिया से बाहर सब पढ़ने लगेंगे तो बिल्कुल पागल हो जाएंगे, इतना ज्यादा। But what we lost, नए बच्चों के लिए मैसेज है, irrational decentralization of healthcare including anesthesia services. क्या हुआ? आपने बिल्कुल से बंद कर दिया सारा शटर. अब सीजरियन तो होना है, कहीं ना कहीं तो जो नॉन एनेस्थेटिस्ट थे, जो इवन पैरामेडिक्स, द फिजियोथेरापी, द ओटी टेक्नीशियंस, मैं जब आज से 99 में गया था, 98 में गया था कटिहार, तो वहां पर एक डीएस, तो उन्होंने मुझसे पूछा था क्या कीजिएगा झाजी, आप जीपी कीजिएगा? मैंने कहा सर जीपी तो आना नहीं, मैं कैसे करूंगा? तो वहां पर इतना चलता था और टेक्नीशियन से एनेस्थीसिया देते थे. मैंने उस ट्रेंड को तोड़ा एंड आई एम वेरी सॉरी टू से कि उतना तो नहीं, लेकिन 30% ट्रेंड वो फिर अभी आ गया कटिहार के बिस्तर वर्ग में. हर जगह, पता नहीं मैं और जगह क्या मैं नहीं कर सकता हूँ, हर जगह वैसा हो गया. देयर आर सो मेनी सोल ऑपरेटर एनेस्थीसियोलॉजिस्ट. आप देखते हैं जो शेर होता है, कुत्ता भी होता है, अपने टेरिटरी को डिफाइन करता है. एंड वी हैव अ टेरिटरी, और हमको उसको छोड़ना नहीं चाहिए था. वहां गलती हुई है, फिर आगे सीखेंगे हम लोग. वी हैव अ टेरिटरी, व्हेन यू विल लीव योर टेरिटरीज इट विल बी कैप्चर्ड बाय others, and at least I think what is my assessment, 30% territory has been captured by the non-anesthesiologists. आपका फ्यूचर में बहुत कॉन्टेस्ट होने जा रहा है. 3 साल पढ़ के यहाँ पेपर प्रेजेंट करके उसके बिना पास नहीं कर सकते एमडी, और वहां पर 3 महीने का ट्रेनिंग लेके एलसास करके, एंड वो चुके ज्यादा रहा फील्ड में, एंड ही इज गिविंग अ वेरी टफ कॉम्पिटिटिव्स. जब मैं अपनी ट्रेन के मेरे स्टूडेंट प्रोफेसर तक भी है, जो भी बन गए बहुत सारे, जब मैं उनका मुरझाया हुआ चेहरा देखता हूँ, बैठ के उनको डिपार्टमेंट में मोबाइल चलाते देखता हूँ, टीचर्स की बात, पीजी की बात मैं नहीं कर रहा हूँ, तो दिल को बहुत चोट लगती, लगता नहीं इतना मेहनत से पढ़ा सिखा, इनके पास काम क्यों? सो दिस इज द चेंज लॉयल्टी ऑफ पीपल. वो आपको छोड़ के दूसरे की तरफ चले गए, वैक्स पर विश्वास है, उन्हीं का ट्रीटमेंट हुआ तो उन्हीं पर वो उसको ज्यादा विश्वास है. नॉन रिकॉग्निशन ऑफ बोनाफाइड वर्क may lead to lack of trust. जो पीजी जिसके बोनाफाइड वर्क को आपने वैल्यू नहीं दिया, उसको बिहेवियरल इश्यूज डेवलप कर सकता है. वो भी बनेगा प्रोफेसर, वो भी वैसे ही करेगा. So that is a question that we have to improve. The road ahead. आगे इतना सारे रिकमेंडेशन है, बहुत सारे उन्होंने 51 रिकमेंडेशन था, उसमें से ये चुना हुआ 7-8 है जो मैंने याद दिया. सब लोग जानते हैं, ये लैंडेड टीम है, इसको बताने की जरूरत नहीं है. एंड लास्ट में मैं अपनी कविता की कुछ 2-3 पंक्तियों से खत्म करना चाहता हूँ. तिमिर कितना भी गहरा हो, तिमिर मीन्स डार्कनेस, तिमिर कितना भी गहरा हो सुबह आती ही है. How deep is darkness, the morning will come. फिर हर डाल पर चिड़िया चहचहाती भी है. Nature has a capacity to rebuild, regain and rejuvenate. तेज कितनी धूप हो, सुनहरी शाम आएगी, आकर कानों में तेरे गीत जीवन का गुनगुनाएगी. धीर रख, धीर मीन्स पेशेंस, धीर रख जो तेरा है चलकर पास आएगा, थके हुए तेरे कंधों को प्यार से थपथपाएगा. जो लोग कोविड में बहुत एनर्जी दे सके. थैंक यू वेरी मच.
Thank you, sir. Thank you so much for the excellent talk. I think you did the justice to the topic, and all of the audience they enjoyed a lot. In fact, this was one of the first session in which there was a clapping in between. So that itself shows how well you were communicating, and the topic was really well justified by you. Thank you so much, sir. I would like to ask Dr. V.K. Prashad sir, sir, please come up to felicitate our speaker, Dr. Ashutosh Jha sir.
Sir, some notes from chairperson.
Sir.
Really a wonderful position, quite technically, quite relevant, and quite up to the mark for the future. Everybody should not follow it, but take it into their life so that they get far. Thank you.
Sir, आशुतोष सर को मैं पहले भी सुना हूँ और इनके व्याख्यान के संबंध में कुछ कहना मेरे लिए गर्व सा है. छोटी सी बात हो जाएगी. मैं अपना अनुभव इनके साथ कुछ जो इनका स्लाइड्स और कुछ पेपर्स था उसके हिसाब से बता रहा हूँ। 86 ईस्वी में मैं मधुबनी सदर अस्पताल में पोस्टेड था। वहाँ प्रेसिडेंट अवार्डेड एक टीचर थे, डॉक्टर नमो नारायण झा, संस्कृत के टीचर। और मेरा वहाँ पेडियाट्रिक्स का क्लिनिक था और मेरे पेडियाट्रिक्स के क्लिनिक में मेरे वहाँ पोस्टिंग ही एज ए पेडियाट्रिशियन थी। तो उसमें वो आए और उनको बैठना पड़ा काफी देर तक। जब मैं हॉस्पिटल से आया तो वो बोले कि डॉक्टर साहब आगे कंपाउंडर कहबो नहीं केला का हमरा विषय नहीं तखन से कहूता ये उनका लैंग्वेज था। तो हम कंपाउंडर को डांटे, इतना देर से तुम बनवासी को हमको खबर नहीं कर सकते थे। जो होता है बोलने का स्टाइल के साथ कर जाते हैं। तो नमो नारायण झा मास्टर साहब ने कहा डॉक्टर साहब नहीं बाजू नहीं बाजू डॉक्टर जी आगे बात के वैल्यू है, आगे वर्ड के टोन के एटीट्यूड के सबके वैल्यू है, आगे एमआर नहीं बजवाना चाहिए। सो वर्ड्स स्टिल आई रिमेंबर। और जब सर की बात सुनी, व्यवहारिकता, आपका एटीट्यूड, आपके सामने वाले भी रीड करते हैं, बहुत सारे लोग फॉलो भी करते हैं, इसीलिए आपका बिहेवियर उनके प्रति एक गार्जियन का होना चाहिए, कभी भाई का होना चाहिए, कभी पिता का होना चाहिए और कभी पुत्र का भी होना चाहिए। ये डॉक्टर्स के लिए आवश्यक है। मैं इस बात के सर का 100% हम लोग अपने लाइफ में कभी न कभी इसको जरूर सर आपका इस पेपर के लिए मैं इसके लिए मैं आपको उस तरह से सम्मानित नहीं कर पाऊंगा जितना मैं अपने मन से सोच रहा था, लेकिन जो व्यवस्था है उसके हिसाब से मेरी तरफ से और व्यवस्था की तरफ से
तुम्हारा साथ में नहीं, तुम्हारे मेरा फोटो दूंगा है, तुम आओ। मैंने कहा ना 3 generations together। हाँ, थैंक यू फॉर इट।
Now I would like to invite our chairpersons, Sir Manoj, sir, please come up, sir. And I would like to request Dr. B.K. Prasad, sir, to hand over and felicitate our GC member national.
मनोज जी को तो सब लोग जानते ही हैं, पूर्व परिचित।
Now I'd like to call Ajit, sir. Sir, please come up.
Yes, sir. Thank you.
Thank you for chairing the session, sir.
ये मेरे लिए सम्मान की बात है कि मैं आपको
Now I would like to call Dr. Ajay Kumar, sir. Sir, please come up.
अजय जी के बिना ये सभा संभव नहीं हो पाता, इसलिए
With this, we come to the end of the session in this hall, but it is not the end, rather the beginning of another mega event, and that is the quiz session for the postgraduate students. And I would like to now invite Dr. Abhyuday Kumar. Dr. Abhyuday Kumar, please come up. And he is now going to conduct the session of quiz for the postgraduate students.
I think all those who are participating for the quiz, they have said, but not please inform their colleagues to look up the Naranga Hall. That is NK Mishra Hall. Please celebrate the NK Mishra Hall. Communicate among your postgraduate students. We are very soon going to start this session. And also, I would like to request you to please switch off your mobiles. I won't say do it in a silent mode. I don't want any interference with the mobiles. No Googling, nothing. So please switch off your mobiles.
Very good afternoon to all of you. So today we are having a quiz round. Preliminary round was done online, and we have got 7 winners in the preliminary round. So the plan is we will first have an eliminator round. Out of the 7, we will take 4. After the eliminator round, out of the 7, we will select the 4, and 4 people will have 3 rounds. To the after that winner will be selected. So I hope all of you are here. All 7 are here. I will call for the names. Okay. So we have 7 finalists. One is Dr. Babli Kumari from AIIMS Patna, Dr. Priyanka Mahapatra from IGMS Patna, Dr. Survi from AIIMS Patna, Dr. Chetan B from AIIMS Patna, Dr. Kiran Premraj from AIIMS Patna, Dr. Neeraj from IGMS Patna, and Dr. Jitendra Pandey from IGMS Patna. So all of you are here. Please raise your hand. Okay, so we have 2 scorers. One is Dr. Neeraj and other is Dr. Vishal Baba. So they are scorers for this quiz, and I will quickly go on to the round. So all the finalists must have an active internet connection over here because we will go on Kahoot platform for eliminator round. Okay. So have your mobile phones ready. So so the ground rules are answer when it's your turn. If you will answer out of the turn, you will lose 5 marks. You can answer the question only once in any of the rounds. No scope for recorrection. In the eliminator round, first of all, we will have the eliminator round here only. And out of the 7, 4 will be selected after that. Okay. An eliminator round will be online round on Kahoot platform. After that, we will have 3 rounds: bullseye round, picture perfect round, and rapid fire. So first of all, I will tell how to play on Kahoot platform. Questions will be showed here only, not on Zoom platform, because we are live here. But some people are still online and seeing it. So I have written in the Zoom screen questions will be displayed, and you have to answer the question by logging into Kahoot.in. So all of you who are finalists, only finalists have to log in here. I have an audience round also, so audience can play there at that time. So all the finalists, 7 finalists, will log into Kahoot.it. Okay, and then you will have to enter the passcode which I will provide. You need to answer by clicking on the option on your mobile. Okay, there will be options shown on the mobile, and you have to click on it. So like this, you will have to open Kahoot.it. Then you will have to enter your name over here. Name, you have to enter your short name. Plus, suppose one is Jitendra. So Jitendra, IGM. That's it. So it will be Ames, Patna, like this. Okay. So you have to enter short name here. Then I will give the passcode. You will have to enter the passcode here, and then you will go. Now the options here will be color coded and shape coded. Like the first one is pink, blue, and shape is also there. So you have to just click the shape. ABCD 1, 2, 3, 4 options will not be there. So you will just click the color coded button when the question will click. Okay. So not for you, this is for me. You have to open Kahoot.it. I have entered Kahoot.com. You will go to Kahoot.it. Okay.
पासवर्ड क्या था?
पासवर्ड अभी नहीं पता है, अभी बताया नहीं।
ऑडियंस को
नहीं अभी नहीं करना,
अभी नहीं करना।
Sorry for the delay. There is some technical issue. Take 5 minutes. So this is the pin code. Only the finalists have to enter it. Please, others don't enter. Okay. This is the passcode. 3115258. Kiran has joined. Chetan has joined. Neeraj IJM has joined. Surbhi joined. Priyanka is the finalist. Okay, sorry. Priyanka Mahapatra. I remember Mahapatra. Okay, Priyanka is joined. 3, 1, 2, 3, 4, 5, 6. No, one is left, no? Who is left? Jitendra. Okay, Jitendra has joined. So we can start now. So we will be starting now. Timer will be on the screen. You have to answer the question in that time. And one thing remember, as early you will remember, you will get more marks. Okay. So the time and it is the marks will be feeded here only. So I cannot manipulate. So you have to answer quickly and correctly. Okay. Fast and furious. So we will start. So we have 1 minute time. Please don't help. Please don't help. The next question. After asking these questions, please all of you come in the front row. So, okay. So the correct answer is 400 kilopascals. And none have answered right, so no issue. Even if anyone have hinted it, but none of you have answered. So it's fair play up till now. So when you are comfortable, tell me. I will go for the next questions. Okay. All of you are comfortable now. So all of you are comfortable now. Can we proceed? Okay. So the next question. So after the first, all are okay. All are at their best. So we will go on to the next question. Next question is on your screen. The Pierce line passes mostly through which intervertebral space? This is a all of you are pro-engineering spinal anesthesia. So let's see. 6. Good, good. That's good. That's good. Now see who is the fastest among these. Who can be fastest final institution? Okay, Neeraj from IGM is top of the list. What is also in the same? Oh my God. So this is going to be tough. So now going for the third question. Which one of the following not likely complication of celiac plexus block? Not. पीछे से आवाज आ रही है तो गलत भी हो सकती है. So don't hear that sound. Okay, so 3 have answered correctly. Okay, so we will go after the third question. What is the score? Computer D. 1911 point. Lovely second. Neeraj IGM third. Cheta and Priyanka fourth. Okay. So going for the fourth question. Recommended ED dose balloon inflation time for ST elevated MI patient is no longer than what? Okay, 5 have answered correctly. That's 90 minutes. Let's see. Good toppings. Vijitendra is on fire. Nice. Vijitendra, bubbly and Suti are getting closer. Neeraj and Kiran. Good. So we are going for the next question. Question number 5. Typical mixed venous oxygen tension in a healthy adult is what? So good, around 90% have correctly. No. My God, is it a tough question? Is it a tough one? So there will not be any change in the score side. Fire. This is not funny now. So we will go for the next question. Okay, 6th question. For every 100 milligram per deciliter increase in blood glucose, the plasma sodium falls by. Three have given correct answer to it. Let's see the results. Yes, Kiran, coming up. Good. Vijitendra is still leading. Now the competition is back. Question number 7 for you. Quicksilver score for sepsis include all except. So 5 have answered it correctly. Come on, IGMS. Come on. 3 questions left. This time. Dhoni. High flow nasal oxygen therapy HFNO2 is considered a failure. It drops index. Take your time with this question. Take your time with this question. Okay, 2 have answered it correctly. Let's see. Fire. Survi on fire. Followed by Neeraj, Kiran, Babli, and Chetan. Okay. So this can change with every question. So don't lose hope. Answer wisely. Next question on your screen. A 23-year-old male child will need an eye gel of what size? Eye gel. 23 inch. Yes, sir. Writing it. Yes, writing eye gel to सब पूछते हैं नहीं चलो करिए Chetan, okay. Surabhi is still topping the list, followed by Chetan, Neeraj, Kiran, Babli, Jitendra. I would love you to go up, really. So the last question, answer wisely, Jitendra. Okay, I have hopes on you. 10. Question number 10. Interpret the following decision. Okay, two have answered it correctly. I would have loved if all of you have answered it correctly. So this is going to be final. Final round is already over. We are going to have the results of the eliminator round. Let's see. The top four will go to the eliminator round. Okay. Hold your breath now. Let's start. I'm happy to do it. Now, two from A and two from ITMS. That is the best result I wanted, personally. So, two from A and two from ITMS. So, I will call upon Neeraj, Surabhi, Chetan, and Jitendra here. We will arrange chairs here.
Request one, please empty that.
So we will not be having. We will arrange the chairs so that the screen is also visible.
Yeah, exactly.
So we will have to arrange that.
सामने करिए एक सारा चेयर आगे नहीं इधर स्क्रीन तो उधर ऐसे घुमा भैया स्क्रीन के साथ ठीक है जी
Be comfortable. Your speech is
room develop naked trying to see the speech.
So we will be having 3 rounds, bullseye round, and then bullseye round, picks up effect round, and rapid fire. Okay, 3 rounds will be there. So this is the bullseye round. The next round is a bullseye round with the 4 contestants which have qualified. 3 multiple choice answers will be asked from each participant in rotation. Suppose I have started from Chetan. Then Chetan followed by Surabhi, Babli, like that. We will go for the first. Then again starting from Chetan, we will go 3 rotations. We will have. Each question will carry 10 marks. Okay. You have 30 seconds to answer each question. There is a negative marking of 5 for wrong response. So there is negative marking in this. Go back to me.
Take your seats.
There will be negative marking. Correct question 5. Go back another. Correct question 10 marks, wrong answer -5. Now the questions will be passed to the next participant. This is important. Okay. The question will be passed to the next participant if you will not answer. But if you will answer the question will not be passed. If I will ask from him, if he don't reply the answer, the question will be passed to the next. But if he will reply, then the question will not be passed. Okay, fine. Because it is a MCQ.
Here we have the team as team 1. So who is team 1?
I will define. I will define the team 1.
Sir, in the past question, there will be no negative.
In the past question, there will be negative marking. Why so? Because of thing.
Person who is answering, whether it's correct or not.
Negative will. In the past question also we will get the negative marking. So don't get it randomly. Get the chance to others know you. Snake. So the team answering the past question will get 50% marks.
Excuse me, I would like to discuss.
And the past question should be answered immediately. No time. Participant we have already given in the first one. So you have to answer immediately. Okay, within 2-3 seconds, something like that. Okay, fine. So the rules are clear to all. So I will go to the questions. Team 1. So the team, I think the rank 1 should get team 1. Okay. Neeraj IGMS, team 1. Team 2, Survi. Team 3, Chetan. Okay. And team 4, Jitan. Vishal, is it clear? 1, 2, 3.
Team 3 is Chetan from me.
Oh.
And team 4 is Chetan from my side.
1, 2, 3, 4, we will rotate that. Yes, huh? So also the hard copy of the rules there.
Yeah.
We are having bullseye round. Is it visible to us? Yes. Should we start? What is this?
Neeraj is going to answer.
Timer is visible. It is not staying there. Strange. नहीं सोचा रहा है कहाँ कर रहा
अभी आज इसके पहले अभी आया था पहले
स्क्रीन शेयर नहीं फुल स्क्रीन शेयर 6 स्लाइड्स है स्क्रीन तो भी है टाइमर भी है तो है ना आपको चलाओ क्या सर टाइमर आप लोग कर लेना मोबाइल में सेट कर सकते हो टाइम आउट कर दो ठीक है टाइमर इज वो कोई एक कर दो टाइमर some limitations here. So the first question on your screen timer on. Ideal in point of reoxidation, the question is for team 1.
Option A.
CO2 more than 90%.
Yes.
I think it's the right answer. If I will be wrong, please inform me. Okay.
Absolutely, check it out.
Can also test. Okay, fine. So we will go to the next question. The next question is for Survi, team 2. Okay, Survi. First to recover after muscle relaxation. Which muscle?
Option.
Okay. Diaphragmatic muscle. So, sorry, strong muscle. The answer is D, abdominal muscles. Okay. Minus 5. So the next question goes to Chetan, T3. Question: which of the following is the earliest sign of lidocaine toxicity from a high blood level? Pardon?
Option C.
Lightheadedness and vigilance. Strong disturbance. The next question goes to Team 4, Jitendra. Which of the following congenital heart disease is not likely to cause arterial air embolism following accidental IV air injection? Not. Sorry, it's wrong also. So left to right side usually don't count there is a CST, okay. So BD is the right answer. Clear? Clear? Can we go for the next round? The next round we will have with Dr. Neeraj. Fifth question for you. 1:2 lakh concentration of adrenaline is how much per ml? Fast should be for you. We will give you 10 seconds because 30 seconds are not been there. 30 seconds हो जाएगा पता है. So, pardon?
Yes.
0.5 mc. No, sorry, it's 5 microgram. कैलोरी का रोज नोट करके 2 से कर रही है. नहीं देते हैं पेट्रोल में. पेट्रोल में देते हैं ना 3 ml. 15 माइक्रोग्राम सबको पता है ना. ठीक है. Can we go to the next question?
In fact, I would say you don't pretend you are confused. Trying to save your points.
Let me marking this one. So the next question goes to Chetan. Which nerve is responsible for sorry? That's okay. So which nerve is responsible for motor efferent limb of the gag reflex? Motor efferent limb. Pass for Chetan. Pass for Jitendra. Sorry, it's Vegas. It's Vegas. Can you go ahead?
Yes.
The next question goes to Chetan. Okay.
Yes.
Chetan. Which is incorrect with regard to the fluid and its content? Incorrect. Option D, RL. RL कितना? Sorry, D बोला ना?
D बोला.
Potassium. It's 131. Chloride is 107. Chloride is 107. So it's wrong. Right content of RL is 107. Okay. Minus 5. Minus 5 awarded from Dr. So then we go for the next question.
Yes.
Next question goes to Dr. Jitendra. In statistical hypothesis testing, a type 1 error is concern will be confused. Oh, he's the right one. Yeah. Okay, so can we go for the next? Question number 9. Question 9 number will be given to Neil. Eutectic mixture of local anesthetic agent is a.
Please don't stop. Please.
गलत भी हो सकता है मैं इसी सेट नहीं करता हूँ
Yes, you are correct.
Right.
I would like to say Neeraj is still leading the show with 20 marks.
Good. Congratulations. So Baka Prince Patna and Jitendra is at what point?
20.
So
no. So Jitendra is at 5.
Okay, good. So Prince Patna need to back up now. So next question going to Surbi. Surbi, everything is on you now. Next question is for Surbi.
Yeah.
Take your time. It's 30 seconds. You have 30 seconds. There is no time bound. 30 seconds is bound. Yeah. So all are minimum ASS standard monitoring except. Right. Is the right answer? So the next question goes to Sheikh. Who discovered carbon dioxide? Sorry. Joseph. Carbon dioxide. So the last question, Jitendra, for you to top the list. Can we go?
Yes.
Next question for Jitendra. The term of anesthesia was coined by whom?
Please don't number.
Cover 6.
Wrong answer. Leonard Scotting is the right answer.
We should have passed.
No, time is up. But time has taken 30 seconds. The time
No, I have already answered now.
But answer 30.
Fine.
Right. I got that. Sorry. So let's take the mic to start. Then after we toppers of the first.
Neither has put 20 marks. Suti has 0 marks. Chetan has -50, and Jitendra has -5.
Yes. Minus. Minus.
Chetan, you have to.
Chetan and Jitendra, please.
Precisely answer the questions now. Okay. But the good thing is that there is no negative marking now. Okay. So now it's at 8%.
In fact, I would like to repeat. Neeraj is rank 1. Then Surati is rank 2. And Jitendra is rank 3. And finally, Chetan is rank 4.
What is the marks of Jitendra?
Jitendra is
minus. They both are in minus.
Okay, so we will go on to the picture perfect round. The rules are there will be 2 questions on a picture. Okay, there will be 2 questions on the same picture. I will show a picture and there will be 2 questions on the same picture. You will have 30 seconds each to answer the question. 30 seconds for each question. Fine. There is no negative marking. Okay. Answering few words to a sentence, there will not be any option. You will have to answer in words or sentences. Question will not be passed to the next participant. Clear? Rules are clear? Thank you.
3-0 for each question.
Each person. So 30 seconds again for each question. And whether passing one or no?
No, not
Not passing. Your candidate has to answer.
So all I have to do that is
Audience, please do not answer till the candidate.
If they will not answer, then we will pass on to the audience.
Okay, it is passed on to you. You can answer.
Fine. So this is a picture perfect round.
So big things are it's not no negative.
Yes. So definitely answer.
Okay,
It starts from here.
it's a person there. So the question will be, I'm like lighting the plane of anesthesia. So the rules are there. 10 marks for each question. 10 plus 10 equals 20 on each picture. Okay. No negative marking. 30 seconds to answer. Fine. We will go. So the first question will go to Neil. So this is the picture. What is the name of this device? Please, audience, please.
Blood separator component. It's the exact name.
Blood bank to blood separator. No, actually, I answer is wrong, sorry. Okay, it's not a blood separator. So the next question for you, then I will go to the audience. Okay. First of all, let me go for the second question. Name one complication of using this device. Okay, this is the correct answer. Okay, this electrolyte is the right answer, but what you did is you identified the device.
But you could not identify, but still you have given the right answer for the second question.
So what
audience?
You can take a chance.
Audience, anyone identify the device? Anyone?
No guessing, I think people are
right.
Ma'am.
So this is
Not that I tell you. Let the postgraduates answer.
This is self-saver. This is used for surgeries in which blood loss is massive. So the next question.
Yes, second question.
Yes.
Yes. For the first, you will be scoring 0 and then second you will be scoring 10. So total 10 for this picture.
0%.
Yes.
Can we go for the next?
Yes.
Just a second.
Question I asked.
Yes, you can go ahead.
Okay, the next question should be, this is the picture. Identify this. Iron lung. This is the wrong answer. Sorry. Mention two conditions in which it is used. Fasting.
No fasting.
Time out.
So for the second one, is going on. Yeah? So you can go 60 seconds to 30 or
You have time to do something.
some of the control knobs.
Right?
Only 6
It's
seconds.
just about 2 seconds left and it's up.
First of all, I would like to give a chance to the other, but they will not get the marks.
Okay, definitely.
If they want, they can answer.
Excellent, excellent. You're very correct. Although I can't give you marks,
But we can give class.
Yeah.
And what are the conditions you said? You
Yes.
Okay, fine.
Yes, sir. This is for you.
Yes, you can start.
Identify the chemical structure. What is this?
Please don't. Please don't.
At least I got the answer.
Right answer. So
So the second question, can you go for the second question on this picture? ये बताएगा चॉकलेट मेरे तरफ
chocolate.
मेरे तरफ से स्पेशल हमारे
या तू पानी उठा कर चॉकलेट बता
Sorry, it's not wrong answer.
Wrong answer. 16 milligrams. So the now last option for Jitendra.
So the last. This device comes under which Michelson reading system A, B, C, D, E, F? Michelson 86 here.
This is actually Michelson E system.
Excellent. Right. The next question for you, timer.
It's going on.
What is the first name of its inventor?
Philip.
Oh, wow.
Audience का एक question है.
We have a school.
No, we will have to after the audience. Okay. One audience question we can have. Okay. So for PG students only.
Who then students only have to answer?
Identify this cylinder.
Status cylinder.
Right as of side. Wrong answer. Right as of side. Wrong answer. Entonox is the right answer. Okay. Pin index please. Right.
Hello, boss to the
Okay, so you will go. Can you look?
Yes, sir. We have the scores. Now, Jitendra is having a top score of 20.
Yeah.
Grand total will be.
Grand total is Neeraj is leading 30 score, Surbi is 0, Chetan is -5, and Jitendra is +50. Neeraj is 30.
15, 0 and -5.
Yeah. And so Surbi and Chetan please come up because you have 0 and -5.
नहीं लोग सोच रहे हैं ये प्राइस तो लेके जाना ही है.
And we have only now.
Neeraj and Jitendra buck up.
They are already bugged up. I am also supporting it. नहीं कर रहा हूँ. वो pricing तो नहीं होगा.
चलो rapid fire.
Rapid fire. We will quickly go over to the. In this round, you will be asked question one by one in 1 minute. You will get 1 minute time. I will ask questions. Okay, in 1 minute. Fine.
Can you set the timer because there is plenty number of questions and the timer will be. Otherwise, we will have to give us time.
चलो कोई
चलो कुछ करते हैं.
ठीक है.
नहीं, we will manage.
नहीं हो जाएगा. I will do that. चलो. पहले rules बात है. Every correct response you will get 5 marks and there is no negative marking.
Fine.
If you answer the question before I complete the question, you will still get 5 marks.
Okay.
So you can interrupt me in between. If you don't know the answer, you can say pass, then I will ask the next question. Or I will wait for 1 minute to finish your time. Okay. So just say pass, then I will go to the next question. None of the questions will be passed to the other participant. Number of questions that will ask in rapid fire depends on how quickly you answer. If the time ends after the start of any question, that question will be completed. Okay. Fine. Find the rules. Scorers, find the rules.
Yes.
No negative.
No negative.
No negative.
The maximum one candidate can score.
We discussed about 1, 5, 6, 7, 8, 9, 10.
10 questions are there and
Pardon?
10 you will get 10 questions now.
Question is not limited, but I have different. I will request them to don't say pass, 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 pass. So what I'm asking that any team can score how much marks in this? Maximum 100. Maximum 100. So that 40 questions.
In fact, Dr. Abhinay, you have actually said how many questions you have put.
35 तो है ही लेकिन मेरा experience है कि 25 ज़्यादा जाएगा.
Okay.
So we'll start from here. We'll start from here. Okay, rapid fire.
You don't have to identify his personality.
Okay, the rules are clear to all. Fine. मेरे पास टाइमर नहीं आ रहा.
Timer is with us, don't worry.
तो मुझे इंटरप्ट करना मेरे पास टाइमर नहीं.
Okay, fine. For 1 minute.
Okay, so ready, Mira? Yes. Can we go? Yes. Dr. Boli for experience for the diagnosis of diabetic mellitus. 6.5. Correct answer. Next methodology, alpha to alpha hour activity is 1600. Correct answer. Calories provided by 1 ml of propofol. The normal mixed venous saturation is about. Which is another but 70 ml. Correct answer. Which side DLT will be used for a male one? Stroke is used for reporting of which type of study? Normal respiratory quotient is. Pass. Mike percent of genomics. Pass. Neurotransmitter responsible for generation of fast pain. Substance P. Wrong answer. Luxury perfusion is caused by which anesthetic agent? Pass. Time up. Is a bit luxury perfusion.
Nahin. Should have an answer. Just don't pass on because you are afraid to answer. Remember, you don't have a negative marking in this part, so just don't pass on hastily. 1 minute time for answering 10 questions, but don't take extra time.
Next question, absolutely.
Okay, you can go.
A patient with morbid obesity comes under which basic classification?
Please don't answer.
Actifimazole is antidote of. Right answer. FDA approval for propofol for induction of GH, what is true? Blood test coefficient of nitrous oxide. Yeah, right answer. Osmolality of K-scale injection. Ventilation is better in which lobe of the lung? Wrong answer. Seesaw sign or M mode of ultrasound signifies. Wrong answer. 1 gram of dextrose provides how much energy? Time out, time.
No, it's not time. You just go. That's it.
Calcium content of fingers like wrong answer.
Time up.
2.7.
Time is not being maintained properly. We are also noting the time here. It's not being maintained properly.
ज़्यादा हो गया कम?
Yes, ज़्यादा हो गया, ज़्यादा time ले लिया.
ये ज़्यादा इसलिए हो गया because I was interrupted in saying the fact.
But you cannot do that, ना? जब rapid fire चल रहा है तो बस चल रहा है.
मुझे भी लगा
हाँ बिल्कुल
Time
और हमारा टाइमिंग कर रहे हैं अभी।
Okay, fine. That's better. You will be helped. Thank you, ma'am.
Okay, so next is Chaitanya. Chaitanya.
So the question is now for Chetan.
ठीक है, चेतन ready? पहले ready कर लेते हैं जैसे हमारे 4 सेकंड ready हो? Maximum amount of heat that can be given by HFNC, please. And blue bag is with reservoir bag can provide FiO2 only. Minimum FiO2 that anesthesia workstation can deliver with nitrous oxide. First public demonstration of ether was done in which year? Induction dose of pitomidate is according to current survival sepsis guidelines, how much minimum fluid should be given rapidly? The increase in CO2 content due to oxyhemoglobin desaturation is particular.
Time up.
Time up. No?
Yes. Time up.
Okay.
Yeah, sir.
Okay, now, so the answers are not note the answer, what you will give. Okay, we will correct, we will check. Okay. I was not expecting
420 from 27 onward. So thanks.
So thanks to answer. Okay, okay. Fine. फर्स्ट क्वेश्चन आएगा तो ऑटोमेटिक कर ठीक 27 क्वेश्चन आएगा ऑन कर स्टार्ट here we define it as less than what
less than 300.
how much correct how much maximum sodium dioxide should be corrected in 24 hours
10 to 12
answer बोला osmolarity of 10% glucose calcium gluconate is
pass.
Lactate content of RF is
pass.
Maximum amount of partial rebreathing loss of reservoir bag can provide a maximum FiO2 balance. Partial rebreathing loss.
Partial. Around 80 to 90%.
Dextran 17 molecular weight loss.
Pass.
Potassium content of isolate T.
5.
Ambu bag. Answer लिखा है
आंसर लिखा
so printed in average check ठीक
Answer
so we will wait for second question which is answered second क्या 28 ना yes question number 28 here it is
yeah how much maximum sodium is
14 we will wait for a few minutes for the result. Okay. Oh, it's over. It's over. We will compile it in a few minutes. Oh, Please wait for 5 minutes. We have audience round also. I forgot.
Again, the audience round for the postgraduates.
No, all.
Okay, for all.
Please wait for 5 minutes. For all. Swati ma'am, you can also participate in audience round. It is GK round. It's a general knowledge round. Okay.
One question from the quiz master also.
One question, two, yeah, one question, four.
One question for the quiz master. That is also general knowledge question.
Okay, ma'am.
Vice versa.
This what our audience round related. I will take only 10 minutes, so don't worry about lunch. I am also hungry. So, the audience one will be on count. So, open count.it. कोई भी audio कोई भी कर So, open kahoot.it. KAHOOT.it. Okay. It's written on the screen also. You have to enter the PIN 8982867. Bubbly Vikram. Right.
Do you have any prizes for the audience as well? Okay, you have the user organizer and you have conducted a quiz for the audience. So that has been decided by you.
So 1, 2, 3, 4, all the solar panel. The room, all the कोई बात नहीं। 10 बस और लोग क्या कर रहे हैं? और लोग क्या कर रहे हैं? इसमें पता नहीं चलता है कौन रॉन्ग आंसर करेगा। इसमें पता नहीं चलता है कुछ नहीं। कुछ पता नहीं चलेगा। डोंट वरी। सिर्फ अच्छा मार्क्स करेगा उसी का पता चलेगा। तुम भी ज्वाइन कर सकते
नहीं मेरी बात नहीं।
तो बस इतना ही चले आगे क्या कर रहे हैं कुछ लोग लाइक नेटवर्क इशू ओके प्राइड में नहीं है इसका क्या मतलब है तो गलत बात सर्टिफिकेट दिलवा देंगे और चले
If you appear in cash prize, then something is great to happen.
Something great will happen. अब इससे ज़्यादा तो बढ़ने वाला नहीं है मेरा खर्चा जरूर है। चले स्टार्ट करें मनीषा ले मेरा मोबाइल कर दूं कैसे लो मेरा मोबाइल ले मेरा मोबाइल मनीषा ले लो मेरा मोबाइल मेरा काम कर रहा है स्टार्ट कर अभी 10 मिनट लगेगा मनीषा हो गया आपका पक्का हुआ मनीषा हो गया चलो ठीक है अनिल भी आ गया आप चलते हैं ठीक है ओके so the questions on your screen now questions on your screen what is the title of first journal devoted to anesthesia 30 seconds title of first journal devoted to anesthesia color coded answers color coded come on no negative marks right are correct rishi kant इतना पीछे लेकिन इसमें आया नंबर गुड गुड so next question it will take hardly 5 minutes over it who coined the term anesthesia इसमें 1 मिनट है रात में 2 बजे सेट किया 30 सेकंड की 1 मिनट कितना करेक्ट है यार so after this Nora who is Nora okay good
हम नहीं हम नीचे
so the next question which queen took chloroform for pain relief during the delivery of her 7th child 1 minute क्वेश्चन नहीं दिख रहा नेटवर्क का प्रॉब्लम है तो क्या करें वन मिनट इसलिए क्या ताकि नेटवर्क इशू जो है वो बैलेंस हो जाए I have answered it correctly. Maybe storage right. Rishi is again. Rishi, पढ़ाई करने लगा क्या? पढ़ाई कर रहा है आजकल. Good. Indian Society of Anesthesiologists was founded in ISA, founded in जहाँ बैठे हो आप लोग. कॉन्फ्रेंस कर रहे हैं आप लोग. Was founded in what? रिजल्ट पसंद आएगा बस 8% 4 मिनट गूगल मत कर लेता और इंटरनेट इसमें तुम लोग तीनों मिल के दे रहे हो क्या ये क्या लोग होता है
It proves that teaching is also an art, and if you are really answering the questions, keep your minds open. I did need it for you, Rishi.
Copying the list. Good going, Nora. Then Satish. Good, Satish. Ritika. Oh, good. Nice and lovely. Fine. Very nice. So the next question. Anil is the highest climber. Up 7 places in this question. Anil. So clap for Anil. Right. So, independent animal research conference of ISA was held at which place? Oh, fire. This is not fire. She has taken 5 correct answer in a row. Wow, fantastic. Good. Next question. First MS anesthesia was started in cinema. Here. MD anesthesia. So MS, first anesthesia was MS section. They used to do MS thing. Like 55 of the correct answer. Oh, इसी का constant है boundary चलता है पंकज अब up. Yes, well, year 55 to 52. Good. So next question for you. Who is the first Indian movie star to be featured on the cover of Time magazine? इनका चौका नहीं है. अब तो 3 ही ऑप्शन है तुम्हारे पास. मुझे पता है इनका चौका नहीं है. Okay, this is last question. You see, Nora Sweta Satish has answered. Last question. Who is the first Indian to win an Oscar award? First one. Answer wisely. किसी खड़ा हो चुका है किसी खड़ा हो चुका है Let's see which topper.
I think the last few months you had been in ESI. That was very good.
So I will call upon the names. The topper is Rishi. Second is Nora. Third is Pankaj. Fourth is Anita. And fifth is Arunima Patel.
Hey, so as how you know, if you don't give the prize, I will be giving some prize to Rishi as well.
Arey wow. Thank you, Mishra. Thank you, Mishra. Thank you so much.
I didn't accept what? What prize I didn't accept? But there will be a prize for you.
Okay. ठीक है ऋषि. Happy. और वो हो जाएगा एक बार happy हो जाएगा. हाँ. So now I will request Vishal to announce the results of the quiz winner.
Well, very well conducted and a fair quiz, and I would like to say that the first runner-up, that is the third position, has been achieved by Surti from AIMS. And the second, first runner-up, that is the second prize by Dr. Jitendra, IGIMS. All of you now know who is the winner, and the winner is none other than Neeraj from IGIMS. You will pick your prizes during the valedictory function. The results have been announced, so I would like to three of you to please be there. All others should also be there. I didn't mean that, but then again, these three people they need to collect their cash prizes during the valedictory function. Please proceed for the lunch. Have your lunch and then be assembled for the valedictory function.